Kansky. It's in Quran also. Come on. पढ़ते नहीं होते? कुछ भी नहीं पढ़ते क्या? नहीं पढ़ते. Most metabolically active retinal layer is. You don't answer. I'm not asking you. You will not get. You will get minus.
Ganglion cell layer. Most metabolic.
No, it's not ganglion. It's not ganglion cell layer. No. Okay. So the correct answers are this. So you start calculating. All right. So meanwhile, we will take audience questions. All right. Are you ready? चलता नहीं है यार. चलाओ. Please connect this. It's not going forward again. नहीं, laptop से कुछ नहीं है. I did not do anything. पीछे से lose है. It's not working, no? Stuck. How many audience question did we, how many audience prizes did we already give up till now? Okay, identify the disease. Teams will not get to answer this. Anyone? Eliminate okay, but teams तो है. No. Anyone would like to answer? Come on. Best disease, correct. So we have one more audience winner here. Give a big round of applause. It's the best disease. Okay, one last audience question when we will announce the team winners, okay? Last question, we are on time. We have the winners. Okay. So if you are able to give me the answer for both the triads, I will give you the audience prize here. The first is ptosis, meiosis, ipsilateral hydrosis of face, and anhydrosis of face, epiphora, photophobia, and blepharopathy. No, don't prompt. Others can. The first one to raise the congenital and Horner's. Is it the correct answer? Answer yes or no? So we have the final winner of the day, Dr. Jethani sir. Give a big round of applause, everybody, and thank you. You have been a wonderful audience. So we have the final winner here, and we are well within time at 10. So congratulations to all the people present here, and great participation. And the get the gifts. We give the gifts now. Take the gifts. Gifts. Ma'am, please come ahead and announce the winner. Ma'am, please come, everybody. I request everyone to please join. Please encourage the people. Please shut off the screen. Photos don't come well with the screen on. Sir, you're late. You missed so many prizes. I had so many airports. Apple airport. All right. Please shut off the screen for Apple airport. Airport. I just said Apple to them. Apple and airport. So everybody a big round of applause. And the winner is team.
Winner is team तो बाद में बताएंगे. पहले तो winner is डॉक्टर श्रुति. श्रुति सबको इतना बांट रही थी, इसने इतनी पढ़ाई की इसके लिए. She should get a good round of applause. And of course इसके साथ में प्रज्ञा. नहीं तो प्रज्ञा मुझे बाहर निकलने मारेगी. So
Question or team trolley?
हाँ.
नहीं, इनको एप्पल दे दो.
बाकी सारी टीम्स विनर हैं क्योंकि वो यहाँ आके उन्होंने पार्टिसिपेट करना ही अपने आप में विनिंग है. ऑल आर हकदार हैं सभी इसके. बट चूंकि हमें कुछ ना कुछ तो बोलना पड़ेगा और किसी न किसी एक टीम को बताना पड़ेगा. हो सकता है उसके क्वेश्चंस इजी हो, ऐसा दूसरों को लग रहा हो. लकी भी हो सकते हैं, बिल्कुल. एंड आई एम सो हैप्पी to announce अभी जो मेरी टीम है जहां मैं पढ़ा रही हूँ, that is number 3. So
MJ.
कोई बात नहीं, आए तो. Number 2 is Sames Medical College, who got 81. And congratulations. And number 3, जो मेरा पहला ओरिजिनल जहां से मैं हूँ, पहला प्यार, तो वो हकदार है पहली फर्स्ट प्राइज के लिए. कॉन्ग्रेचुलेशंस एंड यू गॉट 102 marks. So an appreciable difference. So definitely congratulations.
You please come. We'll give you the gifts. Okay.
वो ट्रॉफी है, ट्रॉफी का सुमित से लेकर आना।
Come for the picture. Please come for the picture. Everybody, very quickly will.
आपकी साड़ी की मैचिंग
Trophy लाने बोला ना, तो audience question लाना punch. All right, very quickly, I request all the audience who answered correctly, who are getting the prize, to stay back on the stage. Ma'am, sir का आप तो आप ले लो, आ जाओ आप. You answered correct, just hold it. Trophies are not there. Yeah. आ जाओ please ma'am, please finish. हो गया फिर ma'am please.
ऑडियंस फ्रेंड
Come.
ऑडियंस कौन प्राइस
Not for you, not for ma'am. No, not for LOC. No. One for Dr. Surbhi Gupta. I promise that the one who comes earliest gets the prize.
Where is the price for Surbhi madam?
Surbhi madam's prize. All right, next session we'll begin with the next session.
Next
Thank you.
नहीं
नहीं मिला? दो? सुमन इसे जाके
प्रज्ञा डॉक्टर प्रज्ञा कम हियर योर प्रेजेंटेशन कम फास्ट हाँ अरे मैं रह गई प्रज्ञा तू भी आ जा
Thank you for your wonderful support. Thank you, Micro Labs. You have been amazing. Thank you so much. I've been eating your head since long. So there is a graph easily going on. Dot. Sumit, kindly go ahead. The trophies to the first 2 teams will be given during inauguration. Don't miss it. First three teams, the top 3 teams do attend the inauguration if you want the trophy. Otherwise, I get the trophy. All right? I love trophies. All right, please collect your trolley bags, girls. Do not leave them here.
Two compliments to Shruti to start and completing in time and trying to conduct things in time. Okay. Secondly, very good commanding presentation and acha sharing, prompting me, badhiya, nice.
Thank you so much. Thank you. Next session, I think. Just बचा है तो कल
Please stay back. We have a very interesting session on cornea and refractive surgery. Please stay back. All the stalwarts, who's and who of cornea and refractive will be here. So I request everyone to stay back in the hall. Dr. Shruti, please.
I don't want this is to be handed over. ये कौन सा session? No, just fill the sign लेना था ना. Sign over उधर ये वाला session का complete कर दो. आकाशा हम all भी हाँ ये चालू करो session talk के बाद मुझे ये चाहिए यार. सर्टिफिकेट जो नहीं है मतलब नहीं देना है. I request everyone to please be seated. This is going to be an interesting session. Do not move on to Hall A. Hall A's are not always good. Hall B's are exciting. Stay back in Hall B. You get more exciting prizes. I have more prizes left from the previous quiz. Ma'am, have you made up your mind? Your friend is telling you to stay back in Hall B. What are you going to do? Jethani sir, ma'am, myopia nahi hai. It is cornea and refractive surgery decoded. Stay back. So I request the moderators, Dr. Sharini Vyas ma'am, to be on the sofa set here, please. And I request panelist Dr. Pushpa Verma. May I किसी को बोलो? Only let us call Dr. Prashant Bhartiya sir on the stage, please. Dr. Pratik, Dr. Monica, please take the seat. Can we have the sofas in front, if you don't mind? Can we redo the PG? Ma'am, आ रहे हो वापस? मैम आ रहे हो? एक प्राइज रखा है मैंने आपके लिए. थोड़ा सोफा प्लीज सामने करवा दीजिए ना जल्दी. Can you tell? इसको can you call the BCC people? Can you just send the BCC? Do one thing before moving on to the next one. भारतीय सर ने बोला सोफा चाहिए. अपने सोफा दे रहे हैं. Come. We were waiting for you. Come. The shift. मैंने कहाँ भेजा मैम? मैं क्यों भेजूंगी? So I call upon Dr. Pushpa Verma Madam, Dr. Amrita Lale, Dr. Prashant Bhartiya Sir, Dr. Pratik, Dr. Monica, Dr. Bharat, Dr. Ankit, Dr. Pratik Tiwari and Dr. Achal to please come ahead and have a seat here. Achal. Achal, in the center. You can sit in the center. सोफा में भी बैक बेंचर्स है हमारे पास. I request the presenters, Dr. Kavita, Dr. Monica, to please upload their presentations. Dr. Rajesh Sinha is here. Dr. Vanati. Can we have the first presentation ready meanwhile? Huh? Yeah. आए थे क्या? साइन कर दो ना ऐसे. प्रज्ञा और मेरी भी साइन कर दो. आप करो ना. मैं
तो मेरा टॉक करूं उसके बाद करती हूँ कॉल. कैन यू कनेक्ट द लैपटॉप?
कल बैठेंगे.
So welcome everyone for the session on refractive surgery, and I hope the PGs also join after breakfast. I think they've gone to take their breakfast. Can I have the laptop? So we start our refractive component with the ICL surgery, which is the very surgery with good results and very good one. So we welcome Dr. Amrita Lale from Bhopal. In spite of all the difficulty, she is over here. Dr. Monica is ready. I think in a sportive spirit, she is here. Dr. Sharadni madam is glittering. Dr. Achal is there with so much of efforts, and we are glad to inform you that she is participating in the ramp walk in the evening. So you should congratulate her. And welcome Dr. Prashant, Dr. Ankit, and everyone over the dais. कमांड आपके पास है मेरे पास है. कमांड आपके पास है मेरे पास है. Yes. Can I start? Can I start? Can I start? Yeah. So it is ICL surgery, practical pearls for smooth surgical journey.
Can we have the timer for 8 minutes, please?
Can you do the slide? It is not coming here. वो पेज नहीं आ रहा तुम्हारा. Full screen कर दो. So first and foremost, the most important thing is understanding the landmarks for ICL surgery. So what we do, you should know all the final parameters which we take as cutoff. So this is an ASOCT picture in which you see the angles are more than 30 degrees. So we are safe to go ahead with the surgery. Can you zoom it? Can you do slide presentation here? इसको
जी
You did a sign and pass.
क्यों यार है तुम्हारे यार? जल्दी करो, टाइम बहुत लेट हो गए. स्लाइड शो करो ना, यहाँ आई नहीं रही बार तुम्हारे.
वो इस पे नहीं आएगा.
मेरे को फुल स्क्रीन चाहिए. डू इट फुल स्क्रीन. Sorry for the interruption. I think God is making us wait so that more people join and learn. I don't know why he's showing the another slide along with this. So it is there. Yeah. So coming to the first. क्या हुआ? आ रहा है ना इसमें? फुल नहीं आ रहा उसमें? ओके ओके. है फोर्ट इसमें? नेक्स्ट सेक्शन में लेट मत करना. हम लोग जल्दी जल्दी खत्म करेंगे फिर, है ना? फुल स्क्रीन कर दो इसको, ये वाला कर दो. So coming to the landmarks, this is an ASOC picture. You see, can I have a pointer please? No. Okay. So the bottom line is the angle to angle, the blue color. The second one, which is the most important one, is spur to spur. And the vertical green line is the AC depth. So the angles are to be above 30, less than 10, 100% no. The internal ACD is 3 millimeter. For very experienced surgeon like Dr. Sharadni madam, it can be 2.8 or. Am I right, madam? So what is the lens size and the vault? What is the lens vault? You take the lens vault as positive when it is above the ATA, that is the angle to angle line. It is a positive lens rise, and below that it is a negative one. Now how to measure STS, that is the spur to spur distance, is with the help of UBM. But the problem with that is it has a bias towards the person who is actually doing the UBM. The slides are coming in a small way. Can you enlarge it? So white to white we all know is limbus to limbus. So extreme large corneas, that is 13.7, and very less, that is 12.1, should not be taken by beginners who are starting the ICL surgery. So what are the modalities to measure the white to white? First and foremost, the most important is the digital caliper, which the surgeon measures itself. The second is the pentacam. You can see it in the down. Pointer is not there. So you can see on the left side of the pentacam in the parameters of horizontal white to white is mentioned in the quadra map. The third is the IOL master. And the fourth and final one is the ASOCT. Now the anterior is the ASOCT, which gives the inbuilt parameters measured by itself. So the sizing, it has to be 1 millimeter above the white to white will be the lens size. What will be the diameter of the lens? So before going to this, we should know the corneal anatomy. What is horizontal, what is vertical. So whenever you see the vault, the horizontal vault is always larger than the vertical vault. And vice versa is for the sulcus. If anybody has any question, they can keep in mind and ask later. This is a very, very important tip, which is very important, especially for the spherical toric IOLs, where we get a higher vault rise post-operatively. So what we do, if you get a higher vault rise, maybe say 1000 microns or 1100 microns, in spite of explanting the ICL, what you can do is just rotate from horizontal to vertical and the vault will decrease by 150 to 200 microns. So we are prevented from explanting an ICL. So now there are two lenses, the ICL and the IPCL. The range for ICL in my, can you remove this? ICL, it ranges from -0.5 to -20. For hyperopia, it is +10. And for astigmatism, it is 6 diopters. Whereas IPCL, it is -1 to -30. Hyperopia +1 to +15 diopters. And astigmatism +0.5 to +10 diopters. And the most important thing is it is customizable, whereas ICL is not customizable. And the power range in ICL is in the steps of 0.5. Whereas in IPCL, it is in steps of 0.0 to 5. So this is the loading surgery. यहीं खड़े हो जाओ, वहाँ लोड भी नहीं हो रहा, कहाँ है पता ही नहीं. कर दो, चालू कर दो. Can you play the video? Okay, I'll give the salient tips for loading. The video is not working. First and foremost is you have to wet your sponge for ICL. Second, the bottle is open. Just put the wet sponge and take out the ICL at the brim. After taking the ICL at the brim, put the left edge of the ICL on the cartridge left edge. Then, with the help of the sponge at the optic haptic junction, hold the sponge, just rotate it clockwise so that the ICL is inserted, and make sure that all the three holes are in a straight line and it is the convex surface up superior, and slightly ICL is popping out from the posterior side. So this is how we load it. But before loading, the point is you fill the cartridge with saline and visco 70-30 ratio. So this is about the loading technique. Can you try once again for video to play? Yeah, but the video is not working. So okay, I'll move it. So what are the various techniques for ICL insertion? There are three techniques: visco insertion, hydro insertion, and hybrid insertion. So visco, in this, you inject the visco, you place the ICL over the iris, then you remove the visco, wait for 60 seconds, see from the center flow whether the visco is still propping out. Once the whole of the visco has come into the anterior chamber, wash the visco. This is the 90-60-30 rule for ICL. I'm sorry that I'm not able to display everything was there in the video. Second is the hydro insertion. In this, the chamber is filled with the hydro. Only very minimal strands of visco are there in the cartridge. So those visco strands can be washed off easily and less rise of post-op IOP. The third is the hybrid insertion, which is the best in that visco plus hydro, both are combined together. So this is the toric marking which we do pre-operatively with manual. People having varion don't need this. So when to use pilocarpine? The second question arises. Suppose you're stuck in the surgery and you want to look for the ICL centration with the hole. Just put a diluted pilocarpine so that you see the central hole exactly coincides with the pupil center. Second is, in case of floppy iris, suppose the iris is popping out of the main incision, just put a drop of pilocarpine so that the popping out stops. The third is, suppose the haptic, one of the trailing haptic, is over the iris and you want to confirm whether it is over or whether it is under the ICL, under the iris. In that case, put a pilocarpine. If you see a notch, it is anterior to iris and you have to tuck it. And the most important is to wash the visco from the angles. The other important surgical tip is incision size for ICL star surgical, that is 3 by 1.5. 3.2 is available in money blade. Then aspirate, always aspirate the visco from side ports. Never overfill in case of ICL. It's a non-touch technique, no irrigation under the ICL. So what is important in surgery is you should not touch anywhere, because it's a virgin eye and you are giving vision to a virgin patient. Don't touch any intraocular structures with your instruments. Loading tips, I have already explained that the three holes has to be in straight line, the upper surface of ICL has to be convex, and the trailing hole on the right side of the ICL injector. So post-operatively, you have to look for vault. Suppose I say the ICL vault is maybe 1000 microns and it is a spherical ICL. What will we do? We will rotate the ICL to vertical aspect and then the vault decreases by 150 to 250 micron, need not excite. This I have already told. Then when are we supposed to do the OCT following the ICL surgery? That is the day 1, day 15 and 3 months. What actually happens, suppose at day 1 the vault height is 749. Day 15 you will find it to be somewhere around 560. And at the 3 months it will be 500. So this is the gradual flattening, which may be because of some retained visco or some other things. Apart from saying 2-3 points I would like to elaborate is you have to understand the corneal anatomy, the sulcus anatomy, where the ciliary body is placed in an inverse pyramid fashion. So what ICL does, why do we take +1, is we want 0.5 indentation in the ciliary sulcus so that it doesn't move. Second important thing is, target for spherical ICL, 500 to 600 microns is the target vault, whereas, yes, concluding. Whereas for toric ICL, you have to target for 6 to 700. Because we all know that the vertical circus and the horizontal circus, we don't want, in any case, we cannot rotate the toric ICL to adjust the vault height. So initially only we target at a higher vault. So thank you all. I am very sorry, and I should say I was not lucky enough to get my video here. So thank you everyone.
ICL surgery. It will help us doing, although I'm not doing this. But
It's a very, very, once the care is out, it's very simple.
it's very simple. It looks very simple.
No, only in the sizing issue. 2 more points I wanted to elaborate about the Lasso formula, the Locas and the Ocas formula, but the time constraints I am unable to elaborate. So that are for the pre-operatively, you can assess the ICL sizing in that. And the important thing is, usually most of the surgeons, they don't measure the pre-operative what they need at the post-operative ward. But all those having iron master can use Lasso formula, which will tell you all of those which are having iron master can use Lasso formula to predict the pre-operatively the ward height which will get post-operatively, and with anterior it's so good that you can actually see the ward during the surgery itself. So you can adjust the ward. You should always keep one size oversize and one undersize ICL if the company allows you to keep 3 ICLs for single patient, because in case the ward height is different, you can just at the table you can adjust and change things. Thank you very much.
Thank you so much. I want to ask one more thing. In the hypermetropia, the upper limit is what you can use in a hypermetropic ICL.
ICL is plus 10.
No,
ICL is
but practically, I think
this question goes to Sharati madam. This question goes to Sharati madam.
because it creates a problem. No?
The problem of limitations is basically because of the
ACD.
depth. You know, so if you have a good AC depth, you can go up to 7, 8, 10. Generally, nobody does, but 7, 8, yes, comfortably. But you have to be 100% sure about the ACD. That is the most important thing. Otherwise, the sizing becomes. Yeah. If the sizing you get proper, then it's a good thing. Hypermetropia, same. Myopia is not a problem, much problem. 18, 20 you can go, and that.
Ma'am, I've done up to minus 28.
Yeah.
Myopia, I've
So that
done up
is-
to minus 28.
The most important tip for very high myo is, in spite of adding 1 to the ICL size, you add 1.5 for about 20.
All right. Amazing discussion. We move on to our next. Can we have a huge round of applause for Dr. Kavita? And ma'am, thank you for traveling all the way and being with us here today. I also welcome Dr. Monica, who's been a great mentor and friend. She's traveled all the way from Baroda to be with us and give insights on microkeratome LASIK. Is it still the best? Welcome, Dr. Monica.
Thank you. And I would like to thank Dr. Amit, Dr. Kavita, Dr. Shruti, and whole IDOS team for this kind invite. So today I stand in front of you all talking about microkeratome LASIK in the era of Contura, Femto, Smile, Silk. So in coming couple of slides, we'll see that is microkeratome LASIK going to stay, or we'll say tata bye-bye to it in coming years. So yes, so there are a variety of microkeratomes available in the market. Now there's nothing new coming up because it's a very well-established technology with SBK giving us linear flaps. And these are the variety of microkeratomes which were available, but now we have come to a conclusion that the linear ones are the best for us because the rotatory microkeratome gives a meniscus configuration, whereas the linear types give a more planar configuration, right? So this is a very busy slide showing what different microkeratomes offer to us, like what depth they can offer, how many seconds they take for the vacuum to establish. And so the whole purpose is old is gold. There is no advancement going on in microkeratome because now it's a 25, 30 years old technology, very well developed, very well established. Why people are not talking about is little bit of marketing strategy, because whatever new comes in, we want to promote it without understanding whether, it is good. Even when Smile was not able to do hyperopic corrections, it was not able to do astigmatic correction, it did not had Z tracker, right? With all those fallacies, we always said Smile is better. I am not against Smile. I just want to put the truth forward. So also we stay in India. In a country like India where people are not very affordable, they are middle class people. I get a lot of patients from Madhya Pradesh who travel from Ratlam, they have to get into army. They are farmer's son. They are not able to afford microkeratome LASIK. And if we do not talk about these in conferences, then it will vanish someday. This is the most important slide. If we take this home, the purpose of my presentation is solved. So basically we say these problems occur in microkeratome like free flaps, buttonhole. I've been practicing LASIK from past 15 years. I have never seen a buttonhole in my life. And free flaps occur if you're not cautious with your vacuum. If you take care of your vacuum, I can promise 99.99% of your flap complications will not be there. And when they're telling you not to reuse the blade, it is a company recommendation. When in Femto, in Smile, we have patient interface, which is bar-coded. Right? So as doctors, we don't have the opportunity to use it. But here to save money, which is so cheaper, which gives you the first eye of microkeratome LASIK is beautiful. There's no problem. But अगर आप उसको घिसते जाओगे, आप एक ही blade से you want to do 8 patients, then God can help you. So now when Femto came, the most advantage was that 90 micron is not possible. But now with SBK and ML7, even 90 micron flaps we can do with microkeratome. I've already emphasized this, that buttonholes and all, we say that these cons are there, but reality check is that it is less than 0.1% in experienced hands. So no buttonholes. And we also said that it creates an uneven flap or a meniscus flap, but those were with Bausch & Lomb microkeratome Zyoptics. That is not true with SBK and ML7. I have been fortunate enough to use almost all the microkeratomes available in the market, which is Zyoptics, then Keraziopendular, ML7, SBK, almost all of them. But then ML7 and SBK are turned out to be the best. Limitations of Smile are hyperopia is still not treatable, though the studies are going on, in future we might have it. And what is very important is that we want to save the tissue, right? When we are talking about higher corrections, we want to save the tissue, whereas in Smile, what people don't talk about is that you have to add 15 to 30 microns of tissue as a flat add. And I felt that it is only for lower diopters, but it is not so. It is even for the higher diopters because the machine is configured in that manner. Because in lower diopters, the lenticule is so thin that you have to add some tissue for the surgeon to become comfortable to extract the lenticule. And sorry, but I would like to say that I have seen surgeons promoting Smile. When they show their live surgery, they'll just show the patient interface going on the patient's eye and coming out. There's no manual dissection which is shown. So, are you fooling the patient? I mean, you tell them it's touchless, it's all laser. It is a manual separation which is going on. There is more manual separation in SMILE than in a microkeratome LASIK. So we can see that we have to take a spatula and we have to separate it. Opaque bubble layer has now been encountered. That was a thing of past. There's a little steep learning curve, but then you can learn SMILE, nothing like that. So pros and cons of LASIK are, it is very predictable. Even compared to PRK, I would say LASIK is a very predictable surgery. The recovery, the wow factor is uncomparable. Next day you feel you had not touched this eye. It is very beautiful. Same is not with femto, because this femto and LASIK will have same results 1 week post-op, but not on the next day. High diopters can be treated. You can correct hyperopia. Thinner flaps are also possible. Con is it is a two-step procedure. Problems with flap may occur. Chances of free flap, folds and stria. But then I have a video on how to do a perfect LASIK surgery. In past 10, 12 years, I've never seen a micro stria. So it's up to your technique, how you do it. So take home message is old is gold. It's cost effective. You should not be reusing the blade. Manual separation is needed in SMILE. No buttonhole with newer microkeratomes. 90 micron flap is possible. Even nasal flap is possible to preserve the corneal anatomy, and its value for money. So what is most important in refractive surgery is that pre-operative workup is the key. And we as surgeons have to understand that the show must go on. You know, they will come on with something new. They'll turn SMILE into silk, right? But then we have to understand that you are important and not the machine. Thank you so much for the patient listening.
So Dr. Monica, lovely presentation. The only thing I was thinking, your patients are either afraid of you, they don't move their eyes, that's why you don't get a buttonhole or a...
I have, no, then I say you have to learn microkeratome LASIK. You can come and learn, you're most welcome.
Yeah, I'll definitely come.
You're most welcome.
Second thing is suction loss do happen when the patient
it doesn't, no. You have to be cautious. I have been practicing it day in and day out, and I can vouch for it. You have to check your suction. It's not up to the patient. In 10 years or 15 years, if I have not had a suction loss, why will you have? I have seen surgeons operating at my center and having such problems because they are not cautious. It's not about the machine, it's about you. And that is what the whole presentation was all about.
Okay, nice.
You can have complications with femto, you can have complications with SMILE. It's about you.
I fully agree with you, Monica. बिकॉज यदि मैं बोलूँ आज से 13 साल पहले जब बहुत ज़्यादा हम लोग नया नया ही सीखते थे, पर ये लगता था कि मशीन ही सब करती. मेरे बेटे का मैंने किया हुआ है इसी से, with this only, and in our इंदौर LASIK laser center, and he is still, मतलब अभी भी आजकल तक उसको चश्मा नहीं लगा है.
नहीं, this is experience which speaks, ma'am. This is a practical thing which we have been seeing.
मेरे को काफी कुछ प्रमोट इसने किया, अमृता ने. अरे करो मैडम, कुछ नहीं, अरे करो मैडम. तो thank you for that.
Correct, ma'am. Thank you. Yeah, please. No, sir. I'll tell you what I do for them. In between, I used to give, but then that's patient-centric. But what I do is, and what ये जो बोल रहे थे ना, see, first thing is you have to make the patient comfortable before you start the surgery. So you don't have to treat X, Y, Z everybody similarly. So what I do is I put first thing Paracane inside the OT in front of me. I never tell my staff to put Paracane outside, because that loosens the epithelium. That in itself can start creating problems. So first problem can start if you are putting Paracane outside the OT, right? Second thing is you have to put Paracane 3 to 4 times, and before you start with your surgery with a forceps, you have to ask the patient, does it hurt? And this I consistently do in each eye of every patient. So once, because हमने 3 बार डाला, राइट, बट वो पेशेंट की कोई अल्कोहलिक है, किसी की सेंसिटिविटी. सर एक और चीज जो what I do is at least from last year, what I do is I play Hanuman Chalisa for all my. No, I mean it. All my cataract and LASIK surgeries, and this is from last year. Not that I have been doing it for years together, but that calms me, that calms my patient. So squeeze वो कब करेगा जब वो anxious है. You have to counsel your patient. You have to calm your patient before the surgery, during the surgery. And also like vacuum check na, you have to do it in 3 ways. Machine aapko batayegi. You have to gently lift your microbe, very gentle. You cannot be, harsh, because फिर retina bahar aa jayega. So you have to be very gentle. You have to gently see that you have, I can swear, if your vacuum is proper, you will not land up into problems. Thank you,
Monica, for such a nice presentation. And I welcome Dr. Rajesh Chinna, Dr. Namrata Madam, and Dr. Vaniti. They are here. We were waiting for you last night, but last moment I just got to know that you all are coming in the morning. So we had a very gala time last night. You can ask Mohita ma'am. So we had a really gala time last night.
I also like to welcome Dr. Pushpa Verma ma'am. Please come ahead if you can join us here. We are missing you here. And I welcome Dr. Namrata ma'am, Dr. Vanati ma'am, Dr. Rajesh Sanasa, welcome. And Dr. Bharat, everybody here. Give a big round of applause for taking so much efforts and traveling across the country to be with us here today.
I'm very sorry for yesterday evening because of some
So
reasons.
one more thing, we all wish you a very, very happy birthday, Rajesh. We'll be having a cake cutting ceremony after the oration. Yeah, his birthday
Thank you.
today. So
Happy birthday.
So he wants
you.
to fly back tonight only, I think, to meet his wife tonight, right? You're flying back tonight or tomorrow?
Tonight.
Yeah. So we want him here, but unfortunately...
But late tonight, actually.
Late tonight.
11:15 flight.
11:15. So for 11:15 also you need to leave 1 hour before.
So thank you very much for inviting me in this wonderful meeting. And Indore, when we reached, I remember we were just discussing, we came in the same flight, Dr. Namrata and myself, and we were just discussing about Brilliant Convention Center that, when we had organized the annual AIOS conference here. So we were just trying to recollect the areas of Brilliant Convention Center where from we used to move around for all these halls and various areas. So, it was a very, nostalgic moment, I would say. So thanks a lot for giving me that kind of a feeling. And I'll be presenting on managing astigmatism in transplanted corneas. Astigmatism is something which is bound to happen if you do keratoplasty. Dr. Monica was talking about Hanuman Chalisa, but even if you, read multiple times Hanuman Chalisa, you will definitely have astigmatism after keratoplasty because you are putting 16 sutures. So what happens that a lot of times we surgeons are very happy that the graft is absolutely crystal clear, but the patient is not happy because the vision is not good because of high astigmatism. So it has to be managed. And when you have a high astigmatism, then the clarity is something like this, and you don't feel comfortable. The astigmatism can be regular, irregular, all sorts of. So the idea of management depends, it depends on the time when the patient comes to you. When a patient comes to you immediately after keratoplasty, very high astigmatism can be because of 2 reasons. Either very tight suture in 1 or 2 axis, or the other thing sometimes which happens is that unequal distribution of tissue between the sutures. Because if you do put initial cardinal sutures, if there is slight unequal distribution, and that you can detect by seeing slightly elevated area in between 2 sutures, that gives you an idea that there is some unequal distribution. So in both the situations, whether it's a tight suture or unequal distribution, you have to replace the sutures. But once the patient has, spent about 3 months to 6 months time, then in that case, if there is astigmatism, then we can do selective suture removal depending upon their topography. Now, most of the literature, you will see that it says that beyond 3 months, you can start doing selective suture removal. The only problem at 3 months is that what happens that when you remove the suture from one axis, the other axis becomes steep. And many times you end up with removing 4 or 5 sutures in order to get some proper topography. So that is why I would prefer to do a selective suture removal after 6 months of surgery, not say 3 months, so that I am in a position to remove multiple sutures without causing any wound gape or wound dehiscence. Sometimes the sutures is so tight. This is one of the cases wherein the pre-suture removal astigmatism was 16.96, and as you remove the suture, suddenly that force disappears and it reduces the astigmatism significantly. If it's a continuous suture, single continuous or double continuous, then in that case you can do suture adjustment, and that also reduces astigmatism. So there are multiple studies which have shown that selective suture removal does reduce astigmatism and does help patients in providing good outcome, having some amount of cylinder, but the prescription can be prescribed by on spectacles, because you can't use RGP contact lens if the sutures have not been removed, because it can sometimes cause breakage of suture, and an exposed and broken suture can incite graft rejection. So it's not advisable to give any form of contact lens. Now, once the sutures are completely removed, then you can think of all these. Like if it's a small refractive error, you can treat with glasses, and a small amount of astigmatism can be managed up to about 3 diopters of astigmatism you can manage with glasses. But if it's more, then you have to use RGP contact lens in order to mask the irregularity of the cornea. Now, the standard designed lens that has been described is the post-graft, Rose-K post-graft lens. It is a reverse geometry lens. So it is basically flatter on the central part and steeper on the peripheral part in order to cover up the peripheral steep graft host junction. But in most of the cases, the graft host junction is not uniformly steep all around, and that is why this lens mostly fails in having a proper stable contact lens over the cornea, and that is why irregular cornea design lenses are used. But of late, these corneal lenses are out of practice in post-keratoplasty, and mostly we use mini-scleral contact lens in order to provide good outcome, and this is how it looks like. And it's a post-DAL case wherein a mini-scleral contact lens has been put, and you just make sure that it doesn't touch in any part. There can be different the tear film behind the lens can have different depth, can have different thickness, but there shouldn't be any touch. Otherwise, it will cause abrasion, it will cause superficial scarring, and that is what we have to think about. And this is one study which we had published regarding the post-keratoplasty contact lens fitting, and mostly the lenses that were fitted were mini-scleral contact lens. Now, coming to the surgical correction of astigmatism, if the patient only has astigmatism and no cataract, then in that case, there can be other options. If there is cataract also, then as you all know, we all do cataract surgery, so we manage along with the cataract surgery. If there is only astigmatism that is to be managed, then there are incisional procedures or laser-assisted procedures. Incisional procedures, we have relaxing incision, astigmatic keratotomy, compression sutures, wedge resection. Relaxing incision combined with compression sutures helps to correct large amount of astigmatism. But the problem is this, that the predictability is very low. And that is why you can have astigmatism in other axes. It can just move on to the other one. So that is why, since it's not predictable, it is hardly used. And mostly laser refractive procedures are used, like topo-guided LASIK or topo-guided surface ablation. This is an example of an arcuate keratotomy done in a keratoplasty, where it is done inside the graft host junction. Similarly, as I said, compression sutures, relaxing incision, and wedge resection have been tried. Ring segment have also been used. That is also used inside the graft host junction to correct some amount of astigmatism. It does help, particularly if you use a single segment of intracorneal ring segment. That reduces astigmatism, or asymmetric segment, but mostly single segment to reduce high astigmatism. But again, the predictability is not as great as an excimer laser procedure. So excimer laser after PK or an LK can be done, PRK can be done, Now, PRK is very effective. However, in all these cases wherein you have to treat astigmatism, wherein you have to do a larger amount of ablation, the risk of haze is high in spite of use of mitomycin C. Now, post PK LASIK or post DALK LASIK is quite effective, but the the best results are seen if you do a staged procedure. You first create a flap including the graft host junction so that you cut the irregular contractile force that is there at the graft host junction, which is causing astigmatism. You relax that part, so you lift it, refloat it, reposit it back, and then there will be some amount of reduction in astigmatism. We had done a study wherein we found out that the average reduction of astigmatism was 2.48 diopters. I think Prashant might be remembering it was during that time when we had done a study. And the average reduction just by creating the flap was 2.48 diopter of astigmatism. So it is always advisable to do create the flap first, lift it up, refloat, and after about 8 to 12 months, you do a refraction once again, see how much is the refractive error, and then lift the flap and then do excimer laser procedure. This is a case wherein the pre-op astigmatism was 7.3, a two-staged LASIK procedure reduced the astigmatism to 2.3 diopters. But this 2.3 diopters is also, has to be corrected by spectacles. So what this was a review article which we published, and what all publications have noted that doing the excimer laser procedure does not mean that you correct it fully. Rather, you correct it to the extent that the patient can be given correction by spectacles and the patient tolerates spectacles. That is important. Now, coming to the last thing, which if the patient has a cataract also, and the correction of cataract also is to be done along with astigmatism, then there are two options. Either you put a toric IOL or you put a spherical IOL, and then if the patient is using minuscule contact lens, continue with the minuscule contact lens. Now the point is that when to select toric and when to select non-toric. Now, if the patient does not require a need for a future keratoplasty, then in that case you can safely use a toric implant. But if the patient does require a future keratoplasty, it's better to put a spherical lens and go ahead with a minuscule contact lens for correction. So this is just an example of correcting the astigmatism. This is a post-DALK cataract, and just move fast. We all keep doing these procedures. So the cataract surgery has been done, and since it's a post-DALK in keratoconus, wherein you know that the risk of rejection, etc., is absolutely minimal. So in such a case, the astigmatism correction can be done by toric implant. Sometimes you have to customize these lenses, and that is why the Indian companies, they are really very handy, because I have used a lens with 11 diopter of astigmatism correction in a patient post DALK, and that has worked quite well. So, I mean, the Indian companies like Pasami or then Biotech or Care Group, they help in these things. So, in conclusion, astigmatism can have a marked deteriorating effect in visual acuity. The graft can be absolutely clear, but the patient will have poor vision. So, we have to consider astigmatism as an important criteria as far as providing good patient satisfaction, because a good patient satisfaction means that patient can bring many more patients to you. Thank you very much.
Thank you, Rajesh. Lovely presentation. And thank you, my friend. He is my friend as well as my guru. He taught me topography, how to read a topography. So he's a very good person.
Thank you. Sorry?
Protocol for patients post-graft, if you're doing excimer post-graft.
Not really as such. Most of the times I hardly, mostly we prefer doing LASIK in all these cases, but sometimes if you do a PRK, then we follow the same protocol. There's no separate protocol for it. So I've also not. We don't have that many cases wherein by which we can make a protocol. So maybe if we combine cases from different centers, maybe we can form a protocol. But as such, there's no protocol. So it's the same as maybe just 10 seconds for one adapter, as is sometimes that is followed most of the places by most of the surgeons. That is what I also follow.
Yeah. Would you prefer doing a femtolastic in such patients post-graft, or you would also go with the microkeratom as well?
Microkeratom definitely is the best.
In
these
post-graft.
cases. Yeah, because it cuts very smoothly, very nicely. But even with femtosecond laser, also you can have a cut. Earlier we used to feel that graft host junction may not get cut by femtosecond, but it gets cut. So that I've done by both methods.
Thank you.
What an amazing CV at the background. I was just wondering, it will take me another session to read it out. Thank you so much for that wonderful time. Please give a big round. I welcome Dr. Vanati, again illustrious CV, a booklet only. Welcome Dr. Vanati.
So this lovely slide is prepared by Shruti, right Shruti? Yeah.
Thank you, Shruti, and thank you for having me in this wonderful meeting here. I'm going to talk to you on lenticular adhesion keratoplasty over the next few minutes. I have no financial interest in the mention of anything during the course of this talk here. So I think keratoconus is one disease where you have, a variety of management options, and it fits in the various stages of keratoconus you're particularly looking at here. So this is one busy slide here, or a flow chart, which I think most of us would have come across while we are studying for our keratoconus exams, or for exams in studying, or when you're writing out your keratoconus essays here. And how does lenticular adhesion keratoplasty really fit into this armamentarium? Most of the surgical approaches for management of keratoplasty has been tissue replacement keratoplasty procedures here. So that's what is conventionally done here. And now I think we are looking at, instead of tissue replacement, we are looking at tissue addition keratoplasty, and how does this help in the refractive outcome or the management of refractive errors in keratoconus patients here. Why do we look at this particular need, or why do we have to explore this option also? It's because that when you are looking at tissue replacement keratoplasties here, it's not free of any disadvantages here. You do have graft rejections here, whether you're looking at full thickness keratoplasties. If you're looking at lamellar keratoplasties, you still have graft rejections, which it's not free of it as well here. You have suture-induced problems in these patients here, and these particularly are not suitable, especially when you're seeing the ocular surface is highly inflamed here. So deep anterior lamellar keratoplasty, I think any talk on keratoconus is not complete if you're not looking at the big bubble DALK here and the wow factor, when you're really able to achieve a good type 2 bubble in these cases here. But then these are again not free of problems here, and you still do have rejections which need to be detected early on to reverse and to get back the visual acuity in such patients here. Hence has come in the option of exploring intrastromal lamellar keratoplasty, or lenticular adhesion keratoplasty, or tissue adhesion keratoplasty. I think it's being called by several names now here, but it was given way back more than 2 decades ago, where it comprises of inserting a donor lenticule into a stromal pocket, which can be created either manually or by using a femtosecond laser here. There are many variations which are now coming into literature about how you would prepare the donor lenticule, whether you're going to use allogenic human lenticules, or whether you're going to use other artificial corneas here. I think Dr. Namrata will be speaking to you about that consequently here. So we looked at in our patients, we did it as a pilot study. I think Rajesh has also done a different series of cases in advanced keratoconus, and here we were looking at patients of progressive keratoconus here, who were not amenable to the conventional thin cornea protocols here. But those days we didn't have the thin cornea protocol; it was just sort of coming in here. So these were eyes in which was progressive keratoconus. You only have to do an aided procedure here. So we thought, why not look at the option of doing a tissue addition and combining it with collagen cross-linking in our particular group of patients here. So that's how we moved on to look at this as a pilot trial. Now we have results of their, we have their postoperative results of them of close to 3 years now, and here you're docking on these keratoconus patients. Of course, remember, you will have to make adjustments to your machine parameters when you are docking these keratoconus eyes. It's not going to be like simple refractive corrections. This is the donor cornea. Here you're using the ALTK microkeratome here for creating an anterior lenticule of the donor cornea, which comprises of the Bowman's membrane and the anterior stroma here. It's about 150 micron thick lenticule here. We get back to the host cornea and open up the femtosecond intralamellar pocket which has been made here, and the donor lenticule, which the epithelium is removed in this, and this is then fashioned or placed into position carefully. Please take care that you do not inadvertently introduce epithelium into that. That's going to compromise your results and you're going to have more problems here. Please take care that the blood doesn't go in. The only difficulty is if you're doing it a day later after correcting the cut, sometimes identifying the entrance becomes a little difficult for these patients. That's a challenge, and the kind of eyes which we took were all VKC eyes here, and so the surface tends to remain inflamed here, so you need to optimize the surface here for these patients here. Following the procedure, you do a conventional accelerated protocol cross-linking for these patients here. So this is what we had done in our cases here, and another similar thing just to show you how the lenticule is implanted. It's a very simple interventional procedure here compared to doing a penetrating or a deep anterior lamellar keratoplasty for our patients here. But the trick here remains in your patient selection here. This is the results, early results of our about 10 patients here, and you would see that 70% of them did have improvement in the unaided visual acuity here in this patient. None of them had a drop in their best corrected visual acuity here. There was a flattening in K1, K2 and Kmax of these patients here, and they were all amenable to a good spectacle correction beyond. And you could see the postoperative results of these patients on day 1, month 1, month 3 and month 6 here. There's compaction of the lenticule, and the lenticule clears up here, and this is how this is 6 months, and now we have close to 3 years of these 10 patients which we are publishing shortly here. And this is how you can see the topography change in these patients as the time progresses. So it does afford you structural stability in these patients, meaning the progression is arrested in these patients, does bring about flattening here. The biomechanical strength parameters as assessed on Corvis improve in some, but not all parameters will show a statistical significance. Of course, we did it only 10 patients here, and the visual acuity was improved, and unaided visual acuity improved in about 70% of our patients here. There's no change in the corneal aberration. The downside of this is you're introducing two interfaces. So I still feel the visual acuity, the quality of vision and the clarity of vision is still better in terms of dark. And in which patients does this work? It works in early keratoconus, mild to moderate keratoconus, less than probably 65-68 Kmax here, and where the quantum of astigmatism is more towards a regular astigmatism, and it is a central nipple cone. So these will be the if and buts of how you choose your patients for better results. So if you're going to do them in others, it's probably not going to work best. It probably can bring you a reduction in the kind of refractive, the amount or magnitude of refractive spectacle correction they can have. So it still probably is in, and the current scenario, it still remains as an interim methodology, but then it is probably here, and we are looking at more and more results when I think researchers are sharing what their experience is with this procedure. Thank you for your patient listening. One.
The thickness.
The corneal thickness, which we do at 120. Just as we would do
Recipient cornea. What is
in
the thickness at what?
In the donor cornea, you're asking.
No, in the recipient cornea.
In the recipient cornea, it's very similar to how you will do a femtoflap LASIK. You'll just do you'll put in your parameters reverse. In your femtoflap plastic, you're just keeping a hinge and you're lifting it up. In this, you don't, you do it the other way around so that your hinge is not there and it cuts all around. So that helps you to take it out.
No, if the patient has a pachymetry of the recipient has 500, 480, 470, at what time you decide that?
So mild keratoconus, which is thin cornea, the one which we took was 350 to 400, the thinnest pachymetry of here, and we did it around 120. So you calculate in the amount you would want to do. Again, we use non-optical grade corneas here. So non-optical grade corneas tend to be thicker as well. So suppose you're cutting with a 180, a 150 or a 200 microns. With compaction, you would have the final perhaps at 6 months going down by 50 to 100 microns.
And in every cornea you do cross-linking?
This was a subset of patients which had to be uniform. So we looked at progressive keratoconus patients here. So that is why we did cross-linking as well. The downside in our study was once you plotted the lenticule, you do not know how the posterior stroma is cross-linked. So that was one downside, and we could not do confocal in most of our patients here to look at the demarcation line. But we do have stability in all our 10 patients here.
Okay, the donor cornea also get cross-linked?
After we put in the lenticule, then we do the cornea. So I think
So
Rajesh
the
has
depth
done
of
in which he
penetration
soaks
is
the, I think he pre-treats the lenticule with, I think you put riboflavin in the pocket, yeah. So those are multiple variations, yeah.
And what about UV?
Yeah. It's a plano where he's done a negative meniscus as well. Powered one.
But you used riboflavin. What about UV?
Yes. Yeah.
Same.
Instead of drops,
Parameters remains the
yeah.
same.
Instead of drops,
So the donor lenticule also get cross-linked in that.
yes. Yeah.
That's what.
Yeah. In mine, I had put topical, which he had put intrastromal, and then you do it. That's so there are several variations. I think we'll need to wait for some more time to collate the results and look at how this is really affecting and helping our patients.
What is the minimum thickness of the cornea of the patient which you can do this?
The one which I did for my patients is 350 to 400, so that there's a uniformity when you're looking. And these were all progressive keratoconus patients.
Any minimum you could suggest?
I think it works best when you do around 350, 380, and your Kmax is around 65 to 68. Then your unaided visual acuity also improves.
There is a significant.
I did do a manual dissection on a 280 cornea. I started with an advanced keratoconus. I did it on a 280 cornea. Patient unaided was 260 and he improved to 636 post-op and went to 69 on refraction. But he had the central cone always had an edema which was persisting at 3 months and was causing intense scattering of light. He made me remove the lenticular and dark and he went in 69 unaided. So that's when I say a single interface always gives you a better quality of vision. I think it should be a combined. It's going to be difficult to separate and say how much it is going to come on. We do this because you're probably going to need an assisted procedure for most of these patients. If you're going to do you probably need to do a contact lens assisted, or you're going to need a lenticule assisted cross-linking for these patients. Otherwise, you take
thickness of lenticule, your donor lenticule you're using?
I took 200 for all these patients.
Thickness of lenticule.
It is a non-optical grade cornea, so 200 with epithelium off.
You make it through microkerator?
We did with an automated microkerator.
Automated microkerator. And all these patients had central cone?
Yes, all these were central cones.
Thank you.
Thank you so much. It was wonderful. Sure. Ma'am has to go to the other hall. Thank you. This CV does not need any introduction. It is an inspiration for everyone in the hall. Ma'am would like to say something.
Number one CV, I think she is always the topper in all India, not only all India, in the Stanford University ranking or number one.
Just one word, pure inspiration. I request everyone to give a big round of applause. Thank you, ma'am.
Thank you. And like Rajesh said, it's very nostalgic to come here because that was our first conference we did together, the first national conference.
And I would again like to thank the entire organizing team of that time as well as now for having me here. And I would be speaking to you about a topic, biosynthetic cornea, which is the new frontier. And we all know that after cataract, corneal blindness is the second commonest cause of blindness in our country. And if we look at the age less than 50 years, then it is the commonest cause of blindness in our country. So all the younger people are affected by it more than the older ones. And there has always been a disparity between what we collect and what we transplant and what we need. So we need 2 lakh transplant only 25,000 and collect 50,000. So there is a need for biosynthetic cornea because of limitations of human donor cornea in the form of limited supply of donor corneas, risk of graft rejection, complications which can occur because of sutures and wound healing, corneal neovascularization or infection, high astigmatism, need for long-term topical steroids, and necessity for long-term patient follow-up. What we've worked on is the bioengineered porcine construct double cross-linked cornea, which we called as the BPCDX, which is obtained from porcine skin, and also it is cross-linked using cross-linking agents. It looks pretty much like this, like a soft contact lens. Comes in 12 millimeters diameter. The various thicknesses which are available vary from 100 to 500 microns, and the shelf life is 2 years. And we look at the scanning electron microscopy, the fibrils are only slightly thicker than the fibrils of the human donor cornea. It has gone through the biological safety in vivo evaluation, ex vivo evaluation in the animal models as well. And if we compare the light transmission of this BPCDX cornea with the human cornea, it is pretty much the same. Just to show the scanning electron microscopy, to show that the fibrils are slightly more tightly packed and thicker as compared to the human donor corneas. As far as epithelial adhesion is concerned, the epithelial cells adhere quite well to it. And we've also done animal studies to look at the pachymetry as well as confocal microscopy. So if you look at the intrastromal keratoplasty, which has been done with the human cornea vis-a-vis which is done with the biosynthetic cornea, the only difference is that this biosynthetic cornea is acellular, and the cells do integrate on its sides from both the anterior part as well as the posterior part, but essentially it remains synthetic and it remains acellular. These are the femtosecond laser parameter pockets that we use, and as was asked previously, you can also make this pocket manually. So this is a case of keratoconus cornea where femtosecond laser is used. A pocket is created and this pocket is opened up. After opening up this pocket, the biosynthetic cornea is taken, triphonated as per the size of the pocket. It is folded just like we used to fold the intraocular lenses in olden times, and is intrastromally placed, and it is followed by the application of a bandage contact lens. So there are no sutures which are required at all, and this is how it looks like on post-op day 1. There is some amount of corneal edema, but it subsides over a period of time. This was the second case that we did, keratoconus and pellucid marginal degeneration, and here the pocket went right up to the periphery because it is very difficult to pass sutures in tuck-in lamellar keratoplasty in pellucid, which Prashant Bharti has also described with Professor Vajpayee. So what we do is we create the pocket right up to the periphery over there, and then subsequently the pocket is again opened up and the biosynthetic cornea is implanted, again measuring the size of the pocket, and this goes right up to the periphery again. This patient also had a cataract, so cataract surgery was done 3 months down the line. And there was no problem at all, and the whole thing was very clear except for the rim of the biosynthetic cornea which can be seen. So this is again the post-operative case, and this was yet another case of large keratoconus where we did it, and K of 85.9 decreased to 57.1, and the astigmatism also became regular. This is the longest follow-up that we have now, 7 years plus, and all that you see is a rim which you see just like we used to see in intact cases. In post-LASIK ectasia also we've tried. So in post-LASIK ectasia, the flap is essentially lifted up and the biosynthetic cornea is triphonated. A slight amount of peripheral pocket is reinforced on all sides, and this is then placed onto the bed, which you can see here, and then the flap is placed on it. So you have noticed that the residual bed is so thin, and that is why possibly the post-LASIK ectasia occurred. And then you have to put a suture in this case because the flap is quite edematous. So this is the post-op picture of the same, and this is the residual bed thickness. This is the biosynthetic cornea in between, and then the flap at the top. So K of 89.2 decreased to 50.4, and pachymetry from 240 increased to 581. Again, in those cases where you have healed keratitis, you can still do it even because you cannot dissect with the help of femtosecond laser. So microkeratome is used, and like I said, you can do it manually also. So this is placed over the bed which is there, followed by a glue, fibrin glue, which is used to paste it on all sides, and then a bandage contact lens is placed on it. And this is the post-op picture, and it does epithelize, although it takes 2 weeks plus to cause epithelialization because it has to epithelialize over the synthetic cornea. And this is the confocal microscopy, the endothelial cells and the nerves, which you can see. And I think in future, if we are able to grow endothelial cells on it, possibly it will not require media and eye banking. We published our results with the Iranian cohort, and Dr. Mehrdad Rafat helped us with this from Sweden in Nature Biotechnology, which has a impact factor of 68.1, and there was no rejection, inflammation, vascularization or scarring in any subject. And now we have close to 70 patients with more than 7 years follow-up, and we didn't have to explant any one of them. These are the results which were done, studied, which was done combined with Professor Rajesh Sinha, intrastromal keratoplasty using biosynthetic cornea versus the biolenticules in advanced keratoconus. And we found that the results were pretty much similar, except in cases with biosynthetic corneas, there was no corneal attrition. So the cornea did not thin out over a period of time. So this is just to show again the results of biosynthetic cornea. We are working on various biomaterials in multicentric trials for endothelial cell culture. And I think these things have a role to play because they are not dependent on human donation. There's no graft rejection, failure, suture-related problems. Eye bank facility is not required and does not preclude a human graft transplant if there is a problem. So from the ICMR, we have concluded a project where we were able to grow endothelial cells on this biosynthetic cornea to get a complete corneal construct, because as of now we have stromal construct. A word about EndoArt, which is also a biosynthetic cornea, where what is essentially done is that it is placed intracamerally inside, and once you place it, this is a patented material, and you inject air bubble. The fluid doesn't go, and so as a result of which the edema which is there, it subsides over a period of time. So this is what it is. And at the conclusion, I would like to welcome all of you to the 5th midterm conference at Ranchi in September and 85th AIOC 2027 at Ahmedabad. And these are our books on corneal transplantation, DALC and DSEC. And thank you very much for your kind attention. So as of now, it is, like I said, it is being manufactured by our Swedish collaborators, and they've got the regulatory approvals also. So I think in the next 3 to 6 months, it should be available commercially. It is a synthetic. It is obtained from porcine collagen. So it is collagen, but from porcine source. And why they do studies on porcine collagen is because porcine is the only material which is FDA approved as far as the synthetic cornea is concerned.
It doesn't have the keratocytes and other.
No, it doesn't. It is acellular.
From the skin, right?
No, you can do that, and we've used it even in healed keratitis on the top, just like you would do a lamellar keratoplasty. So epithelialization occurs on it, but it takes about a couple of weeks to epithelialize. Well adhered to it, which we've seen experimentally also and clinically also. And generally what was being talked about was the total corneal thickness. So the lowest I've gone is 250 microns. And what I do is that I just keep a offset of 100 to 120 microns bed, recipient bed. And then even if the thickness is less, you can still implant it.
Ma'am, is the penetrating rhinoplasty been tried with this?
No, penetrating keratoplasty is not tried with this because there's no endothelium in it.
Yeah, and but I think it won't hydrate, right? Because the stroma won't hydrate, although there's no endothelium.
Okay, what you're saying is that the same material can be used just like an endo art and prevent hydration. That is a possibility which we have not tried.
Okay. Second is, ma'am, like, is there a kind of all the procedures what you have shown is like we have placed it under the flap or something like that. So does placing at a particular depth or like would affect the corneal contouring?
So we've not studied actually whether if you place at 100 microns depth or at 200 microns depth or at 300 will it make a difference. But as of now, as a standard protocol, I just keep an offset of 120 microns just and place it as posteriorly as possible rather than anteriorly. Because otherwise, because it is synthetic, so it works basically by the splinting effect. And I feel if you place it anteriorly, it will not have that splinting effect. With human donor cornea, it is different. It integrates very well into the surrounding corneal tissue and likewise for cares also. So that is why to get that splinting effect, the deeper that you place, the results are better.
And as it been studied, like the graft post junction apposition, if happens, like how is the apposition between the graft post junction?
So like I said, the cells will integrate at the edge of it, and
slowly kind of thing.
yeah.
Thank you.
As you said that the epithelial healing takes a pretty long time in these cases. Around 2 weeks, you said that the epithelium grows.
So if you place it intrastromally, then it doesn't make a difference. But if you place it on the top, which we've done in about 7 to 8 cases, I think, then epithelialization does take 2 weeks or more for the cells to grow on it.
Yeah. Then if suppose the patient develops an epithelial defect or something later on, so have you noticed how the epithelium heals and that defect? They get a trauma?
That we've not worked out yet. See, we don't even know once you placed these synthetic corneas how these corneas are going to behave in future to immunologic response or to infections, because it's a different milieu now.
Thank you so much, ma'am. Thank you so much.
No, we've not had any extrusions. We have not had extrusions because we've kept it like that, but it goes through the pocket. And the anterior ones, no, we've not had that problem at all.
Thank you so much, ma'am. That was an eye-opener for all of us, the innovations. Thank you so much. And we have a lot of retina people in the hall. Is it because of you?
No, it is because of the next session, I'm sure.
It's a house full hall B. A big round of applause. Thank you everyone for being here. Thank you, ma'am. I welcome Dr. Sharadni Vyas, ma'am, to give us insights on PRK now. Please, can you put up the laptop here first? Thank you so much. Do we have Dr. Monica here? Ma'am, we would like to felicitate you. A special trophy was on the way. Sharadni. Ma'am, please come ahead. Till we are setting up, we would like to thank you for being here with us today. Ma'am, would you please like to do the honors? Please come, ma'am. Ma'am, please come. Please, ma'am. Ma'am, please come. Dr. Monica. Can we change the background slide, please? Thank you so much. A beautiful background slide for the photograph. A huge round of applause. Thank you, ma'am, for traveling all the way from Baroda to be with us here today. Thank you so much. We move on to our next talk by Dr. Sharadni, ma'am.
First of all, I'll like to tell Shruti that these are not the retina people who have collected here. These are all the converted refractive surgeons. So, very good morning to everybody. We have heard so many hi-fi talks as of now, and now we are coming to the very, very basic of the cornea and refractive surgery topic. So, first of all, I'd like to know how many people are doing PRK as of today. So, that's a fairly good number. So there are two questions: how many people are still doing PRK, and how many people are now doing PRK? So still is something which is old, and now doing is something which is modified PRK. So the topic which was given to me was the PRK pearls of wisdom, and when, how, and why. But I have converted this into the modern PRK, and the topic now is from surface ablation to biologic refractive surgery. This is very, very important because this ultimately decides the outcome of the PRK. So now why PRK matters? See, I started my refractive surgery in 1995 when there was only PRK. There was no microkeratoma available. So what we used to do is just do the refraction, the topography. There was no tomography at that time. So do topography, do dilated retinal examination, take the patient to examiner laser room, do ablation, 48 hours of patch. After 48 hours, Alfred 4321, and after a month say namaste to the patient. So that was how it was. But nowadays, if you ask me, the workup of PRK patient, it takes significantly longer time than the workup of a patient for LASIK. Why? Because now we understand a lot of biological factors which come into play. So we know that it is a time-tested procedure, and the aim of the PRK is to reshape the cornea. The basic advantage is that it preserves maximum biomechanical integrity, and there are least chances of ectasia. So in other words, I can say that LASIK is a convenience driven surgery because patient is 6 next day, very comfortable, while PRK is a judgmental surgery. So we have to do a lot of judgment pre-operatively as well as post-operatively. Now, when to choose PRK? Why not LASIK in these cases? So there are various indications like refractive. There are a lot of biomechanical cautions where we have to do PRK, enhancement procedures, only PRK, and therapeutic and rehabilitative procedures. Now, refractive indications, we don't have to go into the detail, but one important caution in these patients is that the patient should accept the initial discomfort and slow recovery. Otherwise, he will be one of the most dissatisfied patients and will keep comparing with the LASIK patients. So the situations which requires the biomechanical precautions, these are the most important indications of PRK. The thin but healthy cornea. So every thin cornea should undergo epithelial evaluation as well as Corvis, the biomechanical strength. The post-LASIK, when the residual post-LASIK regression or undercorrection, where the residual bed thickness is not enough to do enhancement by lifting the flap. So there we can do PRK. Then active life contact sports. Of course, in low myopia, PRK is a good option. And when you want to avoid the flap related complications. Now, post-LASIK, the enhancement procedure is post-LASIK residual error and the pseudophakic residual error when there is a significant regular as well as irregular astigmatism. The PRK works very well in irregular astigmatism. Then the most important part is the therapeutic indications. So if you see on one side, there are so many indications of therapeutic PRK, but the goal is that PRK is safe in these cases where we have to do optical improvement and the target should not be a refractive perfection. Like in case of EBMD or recurrent corneal erosions, if you do LASIK, the patient will be dissatisfied throughout the life. The Schalzmann nodular degenerations, you have to do multi-stages. So a lot of irregular astigmatism. So you improve the best corrected visual acuity. You try to minimize the refractive error, but don't promise emetropia for these patients. Now, when not to do indication, not to do the PRK, the routine contraindications are there. But the most important indication is unrealistic expectations by the patient. The LASIK improves the vision very fast, while PRK takes long time and the patient has to really wait for long time. And an important caution here is a bad ocular surface can change a good ablation into a bad healing problem, because healing is very, very important in PRK patients. Now, as I said, it has become a biological PRK nowadays, biological refractive surgery. So what happens that the PRK breaks the epithelial as well as stromal barrier. So the final results depend on multiple factors which have to be considered pre-operatively as well as post-operatively. The epithelial healing is one of the important factor. Stromal remodulation is very, very important. Keratocyte activation, again it can cause regression and haze formation. The nerve regeneration, the tear film recovery, and inflammatory control. If these three factors are not considered, that the patient will be asymptomatic all throughout, and he'll come with the neuropathic pain which cannot be relieved with very easy means. So we have to understand that the laser only performs ablation, while the biology is going to determine your outcome. So all these factors will determine the outcome. Even if you do best ablation, then also it is not going to improve the things. Now, the technique pearls are that we know that we have to do all these investigations, including the ocular surface, the topography and tomography, epithelial mapping. The important factor is mesopic pupil size, which will determine the night vision problems. And the preoperative counseling, as Dr. Monica was saying, preoperative counseling in PRK patient is one of the most important factors. Now, intraoperative pearls are that epithelial removal. You have all the means of manual, alcohol and trans PRK. Only thing is, if you are doing trans PRK, try to do epithelial mapping beforehand. You know, sometimes the epithelium is thin. So if the epithelium is thin, 40 micron, and what you do in trans PRK is 50 micron. So you have 10 millimeter which you are going to extra fire, and that will affect the refractive outcome. If one of the patients I had a 60 micron epithelium. So if you do 50, you still have the 10 millimeter epithelium on the stromal bed. Again, you will not be able to do the proper correction. The outcome will be unexpected. Then avoid stromal hydration. So as soon as you remove the epithelium, the hydration or dehydration is very important. So the ablation has to be very, very fast. The optical zone and the dental transition zone are very important. And the intraoperative use of mitomycin C has to be very judiciously taken care of. Post-operatively, it's routine post-operative. Now, considering certain special situations like topo-guided PRK, so it is primarily a repair station. It's not a primary surgery. So basically it is indicated, specifically indicated in patients with keratoconus when you have to do cross-linking with PRK. In decentered ablation, it works very well. In post-LASIK irregularity, as I said, irregular astigmatism, it works very well. Same thing, post-RK haze and irregularity. So, remove the irregular astigmatism and it reduces the corneal higher order aberrations with the topography guided correction. Now, PRK with cross-linking, I'll just say one word. Do not promise emetropia for these patients at any time. Don't say that I am going to correct your vision. say I'm going to correct your best corrected vision. Okay, that is the important point. And epithelial mapping, as I said, that this is very important, and if possible every patient should undergo. And you have to sometimes there may be a hidden keratoconus which may not be which we may not be able to see in the anterior surface, and there may be a donut pattern in the epithelium. So that is very important. So never trust topography alone, especially in corneas which looks little abnormal. Epithelial may be hiding some of the other factors. Like this patient also, same thing. There is a epithelial hyperplasia, and if you see the stroma below, that is very irregular. So the outcome of PRK in this patient is going to be very bad. So the principle is that minimize the surface ablation, improve the ocular surface, control the controlled use of steroids, MMC personalization, and be aware of the nerve recovery, and prevent the dry eye. So the PRK has now become a biologic refractive surgery, and a complete workup is very, very important. The biomechanics will determine the safety, the higher order aberrations will decide the quality of vision, mitomycin will decide the regression and haze, and the most important thing is that the best PRK is the most conservative PRK. That word we have to keep it in mind. So in conclusion, I'll say when we move from surface ablation to surface intelligence, the optics, the biomechanics, the epithelial analysis, and the wound healing, all these factors must agree before we fire the laser. Thank you.
Thank you. I would request Dr. Namrata Madam and Rajesh Sinha to please felicitate Dr. Sharadni Vyas Madam. And I will request all the panelists to join for this photo, because the two national faculties are leaving in another hall. So I kindly request you to join here. Sorry, Trisha, but this was the need of the hour. Palak, you also join here. Come on, join. Thank you very much. Trisha, continue with your talk. Thank you. Thank you.
चलो एक क्लिनिक कर लेते फिर लगाओ
ऑन नहीं हो रहा पासवर्ड नहीं खुल रहा है ऑन नहीं हो रहा लैपटॉप पासवर्ड आता है ना वो आ नहीं रहा हाँ अब आ रहा बट इस पे नहीं दिख रहा ना यहीं से चलाना पड़ेगा ना यहाँ से स्क्रीन नहीं चल रही Yeah, I'll be fast. So we all know that the cornea must be clear for a patient to see, but in some cases we run out of corneas before we run out of hope. So this talk is just a small effort to show you what we can do next in such cases. So we know that, some corneas, some patients, we have exhausted every conventional option, like multiple failed grafts, or patients with surface disease, Stevens-Johnson syndrome sequelae, or aniridia with limbal stem cell deficiency. So in these patients, keratoprosthesis is one procedure which can be done. It is a procedure where a diseased cornea is replaced with an artificial cornea to restore the visual function. So there are different types of keratoprosthesis, and basically we decide on the basis if the surface is dry or wet. I'll be talking about the type 1 K-Pro, which is an Oro K-Pro. It's a double-plated PMMA device. It has a front plate. Then the cornea is inserted. It has a collar button shaped device, and then the back plate is put and a titanium locking ring is done. It provides a visual field of around 60 degrees. So we have an experience of about 7 cases, the longest follow-up being 4 years. And the various indications for which I have done a type 1 K-Pro is failed graft, Stevens-Johnson syndrome. One patient had aniridia with nystagmus and limbal stem cell deficiency with foveal hypoplasia. And the other patient he was a young patient, operated RD corneal scar with aphakia. Now the case selection really matters in these patients because success is not determined only by the status of cornea. So it depends how the ocular surface is. We have to see the blink rate, we have to see the Schirmers, we have to see how wet the surface is. Is there any pre-existing glaucoma, or are we anticipating glaucoma in future? What is the status of retina, and what is the compliance of the patient? Patient has to be told about the cosmetic results, and he has to follow up lifelong with drops, which are non-negotiable. So I'll just skip the slide. That was how we assemble a K-Pro. Now I just come to one case. He was a 50-year-old male patient. Now this patient had an operated therapeutic graft done 3 years back outside, and post therapeutic graft he developed secondary glaucoma with aphakia. Then an AGV was implanted there, but unfortunately the AGV extruded. So the AGV explantation was done, and Avastin injection was put there. Now the patient presented with the corneal opacity, PL/PR, other eye was PL negative. So we faced with certain challenges, like since it was already operated, there were extensive peripheral synechiae, there was already conjunctival scarring in the supratemporal quadrant, but since the patient had high IOP with a failed vascularized graft, we definitely knew that an AGV had to be reimplanted. So we planned type 1 keratoprosthesis with a repeat AGV in this patient. I'll just go quickly through the surgical highlights. So we always assemble the K-Pro first before doing host trephination. You can see there are extensive synechia. So I do flush cutting and try to save as much iris as possible. The K-Pro is assembled and now sutured onto the host cornea. And finally the AGV tube is also inserted in its final position and closure is done. This patient had a very good visual recovery, improving from hand movement to 6/18, and it's almost 3 years since the last follow-up. And these are the post-op pictures of day 1, 1 week, 1 month, and 3 years. These are some of the other cases. This was a young boy. He was around 25-30 years old. He had aniridia with limbal stem cell deficiency and nystagmus. So we did a type 1 K-Pro for him. So our 4-year anatomic success is 100%. 28% patients had BCV of more than 20/40. We did encounter some complications in the way. One patient had post-op graft infection, but we managed with fortified topical antibiotics. One patient had a retroprosthetic membrane for which we were able to do NDR. And 4 patients we had anticipated glaucoma, so we already implanted AGV along with the type 1 K-Pro. We did not inquire any device loss in any of these patients. So surgical pearls, few that you always assemble the K-Pro before you do the host trephination. Sizing of the trephination, central making the 3 mm punch is very, very important because that will help in the final outcome about how the surface is, are there any Dellens or epidefects post-surgery. Always put a bandage contact lens in these patients for lifelong, and you have to change them every 3 months, and always plan a glaucoma treatment before and not after the procedure. So it is not only the surgery, but the follow-up is also very important, and then that is the only time, that is how we can prevent all these complications and pick them up early and manage them. So what we learned is that though K-Pro reliably clears the cornea and it can provide functional vision, but glaucoma management is important, and finally the status of retina determines the final visual outcome. So though we had a stable surface and clear optical axis and everything, but 3 of our patients had limited visual gain because of pre-existing retinal disease. K-Pro is not a miracle. It is a meticulous surgery followed by lifelong care, but for selected patients, it can restore meaningful vision. I'm always thankful for my patients. So this was the patient for whom we did a K-Pro with repeat AGV, and he's maintaining good functional vision. He comes independently for follow-ups. And my slide would be incomplete without acknowledging my mentors, Dr. Himanshu, Dr. Ritu, and Dr. Sumit and Dr. Menak for all the support. Thank you.
Is Sumit your mentor or your Sumit?
He's my colleague.
Thank you everyone for your patient listening. Thank you for staying with us throughout the session. Now quickly welcome all the panelists and the judges and the chairperson of the film festival. Please come ahead. Trusha, can you take over and describe the rules quickly so that I get the sheets? And
इसको निकाल देना.
please welcome Dr. Sharda sir as well. That will not pick up a
Seated everyone, we'll be starting with the IDOS Film Festival.
The innovative and economic technique. So as you all know, the trabeculectomy, actually the penetrating nature of trabeculectomy actually has some complication, but still is the gold standard. And the deep sclerectomy is the non-penetrating surgery, is the design to lower the intraocular pressure while actually avoiding the full thickness entry into the antechamber. So unlike the conventional trabeculectomy, it create the actually in the trabeculectomy we create the direct communication between the antechamber to subconjunctival space. But in the deep sclerectomy, the integrity of the trabecular descent membrane is preserved. So when we see the study, when the deep sclerectomy is actually still the success rate is slightly less, but actually it still is actually very less complication, chances of the very less complication. Why this reason? This technique also exists in nowadays. Actually, this is the old technique, but now that the many modifications have been done, there are the many like a collagen implants or some chromic catgut or snub clip, but these are the implant actually not available in the India also. But we can use the some collagen implant or T-plux. These are slightly permanent implant, so these can give the slightly long-term outcome. But some like the Helon GB or collagen implant, the short term actually they are absorbed in sometimes, so they give the very less results. In the our technique is the very economic and subflap meta suture. So what is the subflap meta suture? This is the subflap meta suture is the novel, simple, actually the new economical technique, which the 10-0 nylon suture is it's called metas orientation. Is the suture is under and is reaching beyond the edge of the actually superficial scleral flap. So this subflap meta suture act as a hinge, maintaining the decompression space, and actually due to and augmenting the IOP loan. Sorry. Just come. Some volume hai? Please give the volume. Volume.
हाँ मैं
वॉल्यूम देखिए. Facial. scleral flap was deposited over the metal suture and secured with the 10-0 nylon suture. अब एक काम करिए, डायरेक्ट चला दीजिए प्लीज, डायरेक्ट चला दीजिए विद पीपीटी में होगा, इसलिए मैं बोला पीपीटी में नहीं है ना, नहीं है पीपीटी में, ये है, आएगा कि नहीं, चलिए मैं बोल देता हूँ, नहीं वो ऑडियो बाद में ही है, नहीं शुरू से ही, हेडफोन चलिए मैं बोल देता हूँ. So I start in the phonics base flap about 6 to 7 mm. Bleeders are then cauterized with bipolar plate filled cautery. Marking is done with the caliper 5x4 or 4 partial thickness scleral incision with 50 number blade. क्या है भाई?
PC only चला गया ना, PC only चला गया सर.
It's okay. So these are the few modifications. So I start in the phonics base flap about 6 to 7 mm. Bleeders are then cauterized with bipolar plate filled cautery. Marking is done with the caliper 5x4 or 4 partial thickness scleral incision with 50 number blade. So technically, a rectangle 5x4 mm superficial scleral flap is fashioned using crescent blade and dissected forward until the corneal periphery reached. This raised flap is dissected 1 mm into clear cornea. The flap is hinged. A smaller, deeper second scleral flap is outlined and dissects forward until the Slem's canal reached. Then I shifted temporarily to clear corneal phacoemulsification, so AC entered with the 2.8 keratome. After staining of the anti-lens capsule access is done with the help of Utrata forceps, followed by the hydrodissection, and then phacoemulsification by the stop and chop technique, and PCL implantation is done after cortical aspiration. Then pilocarpine is used to construction of the pupil and hydrosis is done. Then I shifted superior side. And after that, deeper scleral flap is dissected forward until the Slem's canal is open. Identification and opening of Slem's canal is the secret of success of NPDS. So here we can see aqueous percolation. Beyond this stage, trabecular meshwork will be identified and percolation of the aqueous humor will begin. At this stage of the procedure, aqueous humor was seen to percolate through the remaining thin trabeculodesmate membrane. Peeling of the Slem's canal enhanced the further percolation. The deeper scleral flap then excised. The percolating aqueous will accumulate under the superior scleral flap, forming lac. This is called decompression space. Afterward, aqueous will flow into the subconjunctival space and forming the bleb through the cut end of the Slem's canal, occasionally through the supraciliary space. After the 10-0 nylon suture, metal suture that extended 2 mm beyond the superficial scleral flap was secured under the flap. Suture is non-absorbable and widely available. After that, superficial scleral flap was deposited over the metal suture and secured with the 10-0 nylon suture without releasable suture, and knot should be buried. And conjunctiva carefully closed with a interrupted 10-0 suture. So we can say that this is the simple economical step enhance the efficacy of the deep sclerectomy in lowering the elevated IP by adding the subflap matter 10-0 nylon suture after excision of the So as we see, we actually applied the 10-0 nylon suture in the just under the superficial scalar flap, and this is the 2 mm is actually remaining. So this flap actually is slightly elevated with this suture. And one thing more, actually when we tighten this suture, the widening of the Schlemm's can also occur. So why this region the aqueous percolation is more, slightly more. And second thing is the edge of the flap is not actually which actually touches the inferior surface. One is actually much most actually that we encounter the one complication like the perforation. Sometimes that we can actually find the tubercular descent membrane disturbed, so we can convert into the tuberculectomy. But in this type of the cases, it is actually requires some learning curve also. So why this region actually the hypotony is very high in this type of cases. In my cases, actually I did more than 100 cases in the last 3 years. Actually, in earlier we can find the very hypotonous eye, like IOP is like 2 or 3, but the chamber is normal. So why this region? But in the long term, IOP control is slightly more in this type of cases. So in the there are the few study done is like the Devin Maheshwari is also done this study. This study also demonstrate the actually potential MMC augmented NPDS alone or with without phacoemulsification is valuable surgical option for the advanced glaucoma. Also provide the very good IOP control. There are the few study also have been done. So we conclude that the potential NPDS alone or without phacoemulsification is actually valuable surgical option for advanced glaucoma. But these which are actually very simple, economic and cost-effective modification of NPDS. So that provide the significant advantage over the conventional deep sclerectomy. Thank you so much.
Excellent presentation, sir. I would like to invite Dr. Rajendra Agrawal to please come on stage and felicitate sir with a memento.
No, no, ma'am. No, this is the tubercular descent membrane is remain. So this actually preserve the anti-chamber even. We actually not enter the inside.
Thank you, sir. I will invite Shweta Walia, ma'am. Shweta, ma'am, please come.
Dear judges, will start the judgment with this. Out of 100 marks, you have to give this.
वो बोल रही है ना उसने सेव कर रखा है वीडियोस डाले हुए
Number 3. Number 3 video. Lights बंद करवा दो. All the lights.
खड़े रहना है मेरे को
Amniotic membrane grafting in ocular surface disorders. The placenta is temporary yet a powerful organ that supports life. Its innermost layer, amniotic membrane, contains key biological factors like the Pentrix 3 and the heavy chain hyaluronic complex. These components offer anti-inflammatory, anti-scarring, and epithelial promoting properties. When used as amniotic membrane grafting, it promotes healing, restores surface integrity, and improves outcome for wide range of ocular surface disorder. Now, amniotic membrane can either be a freshly harvested, dry cryopreserved, or a procera. For a freshly harvested AMG, we need to wait for a plant cesarean section and the patient must be serologically negative. So over here you can see that the amniotic membrane has been removed from placenta, and then it is washed with copious amount of saline to remove all the debris in the blood clot, and then it is transferred to a solution of betadine followed by antibiotic solution. This is dry cryopreserved amniotic membrane grafting. This has to be put in saline and then used. This is Procara, very easy to use. The disc can simply be put into the patient's eye in the OPD. You can use either a fibrin glue or sutures to secure AMG. We can use either inlay, overlay or multi-layer technique. This is inlay technique of suturing. This is overlay technique. In multi-layer, we put multiple layers of amniotic membrane, and in slit, limbal stem cell with AMG is used. Here I highlight my technique of modified purse string suturing technique, in which we put multiple chain stitch type of sutures, and the only care that you need to take is that the second pass should begin slightly behind the first pass, and in the end you open up all the loops, and as we pull the suture, all the suture is buried underneath. So let's see in the patient's eye. So we start putting chain stitch, taking care that the next pass is just starts behind the first pass, and in the end you open up all the loops, and as you pull the suture, the entire suture goes underneath the amniotic membrane, and you can see how snugly amniotic membrane is fitting onto the patient's cornea, just like you have used glue. So this is second case. So you can see chain stitch type of suture is coming. Care has to be taken that the next pass should be slightly behind the first pass. So all the sutures have been passed, and in the end you open up the loops, and as you pull the suture, the entire suture goes underneath the amniotic membrane, and amniotic membrane fits snugly onto the cornea. Just to highlight, to say that it appears just as we have used glue. To conclude, amniotic membrane is a very versatile and effective tool, and we can definitely modify our suturing techniques to improve the surgical efficiency and patient outcome.
I would like to invite Jithani sir to please come and felicitate Shweta ma'am. And Dr. Prateek Mahajan, please come on stage.
एक रेटिना सर्जन हिमालय पर तपस्या कर रहे हैं।
मैं तुम्हारी तपस्या से प्रसन्न हुई वत्स। क्या तुम्हें रेटिना सेटअप लगाना है?
हाँ।
क्या चाहिए? लेजर और विट्रेक्टमी मशीन?
हाँ माँ।
और ओसीटी?
हाँ माँ हाँ।
और फ्लोरोसेंट एंजियोग्राफी?
अब कहाँ डाई इंजेक्ट करो, फिर रिएक्शन की भी रिस्क होती है। FFA तो रहने ही दो।
FFA भी रख लो बेटा, काम आएगा।
आपने मेरी आंखें खोल दी माँ। I will not underestimate the power of FFA.
Excellent video, sir. Now I'll invite Preeti Rawat ma'am to please come and felicitate Prateek sir. And Dr. Prashant, आपकी next video.
Huge round of applause for Sir and
अरे
अब कौन से भगवान आ रहे हैं?
कोई भगवान नहीं, हैवान, कॉर्नियल हैवान।
है तू नींद हूँ मैं, दोनों मिले रात बने, रोज यही मांगू दुआ, तेरी मेरी बात बने, बात बने। रंग शरबतों का, तू मीठे घाट का पानी, मुझे खुद में घोल दे तो मेरे यार नाक बन जानी। रंग शरबतों का, तू मीठे घाट का पानी, मैं रंग शरबतों का, तू मीठे घाट का पानी, मुझे खुद में घोल दे तो मेरे यार बात बन जानी। रंग शरबतों का, तू मीठे घाट का पानी, मैं रंग शरबतों का, तू मीठे घाट का पानी।
प्यार की बतियाँ क्या समझावा, जागते रतियाँ रोज बितावा, इससे आगे अब मैं क्या कहूँ। ओ यार कुछ बोल के लकियाँ सबके जावा, मांग ले पतियाँ आज दुआवा, इससे आगे अब मैं क्या कहूँ।
चाहतों का मैं जैसे कोई नादानी, तू ढंग चाहतों का मैं जैसे कोई नादानी, मुझे खुद से जोड़ दे तो मेरे यार बात बन जानी। रंग शरबतों का, तू मीठे घाट का पानी, मैं रंग शरबतों का, तू मीठे घाट का पानी।
Thank you. Basically, this was just to show that we didn't do a complete tattooing in this case. We did it in the center, and we tried to create a pattern in the periphery that gave a little better match. Thank you.
Sorry. Sir, momento. Okay. Shakya sir, please.
Wow, yes, wait till jalebi.
I'd like to invite Dr. Pore sir for the next video.
When I submitted video in January, I was not aware of that voice layover is allowed. So I will speak for myself. Please start. So what the
You missed
opportunity I
it.
seized?
I seized the opportunity, season 1.
Okay.
Lower lid mass in this
Thank you.
gentleman was incised considering a cyst. But treatment of choice was wide local eyelid excision, taking into account the rapid regrowth. A huge lid defect was created. Your cartilage harvested to reconstruct the posterior lamella. A flap is fashioned from his forehead to reconstruct his lower lid. Flap rotation can be very well seen. Both the canthi are recreated. Undermining and closure of donor area done. The mouse turned out to be an invasive eyelid carcinoma with abdominal metastasis. Season 2. This young boy with non-responding post-traumatic orbital cellulitis approached with restricted ocular motility in his left eye. CT orbit showed radio-opaque foreign body. With transconjunctival orbitotomy, which succeeded in delivering his first wooden piece. The second, the third, the fourth. Finger palpation was done, and you see more and more coming out. We delivered total of 8 foreign bodies. Scarless closure done. Complete resolution with full ocular motility. Season 3. This middle-aged gentleman was operated for his maxilla and jaw fracture by plastic surgeon who approached us with restricted elevation and enophthalmos. Untreated orbital floor fracture confirmed on CT scan. Now we have diplopia and enophthalmos as our challenges. Under GA, FDT confirmed restricted elevation. Scarless approach to orbital floor is taken. Fracture defect is covered with titanium mesh and secured with titanium screws. FDT confirmed free elevation. Layer-wise closure is done. With this we offered cosmetic betterment, abolishment of diplopia, and enophthalmos correction. You missed.
Thank you so much.
Excellent talk, sir. I'd like to invite Ulka ma'am to please give the memento.
It was nice presentation. All the
Good morning. In surgical training, we are taught what to do, but what truly shapes. Good morning. In surgical training, we are taught what to do, but what truly shapes a surgeon are complications. Today, 3 real cases, 3 real lessons that permanently changed my cornea practice. My first case, a young woman, uneventful LASIK, post-op day 1, 6x6. She was happy, I was happy. Day 15, she returned with vision drop. Flaps dry, cause eye rubbing. We took her to OT, alcohol wash, epithelial debridement, flap lifted, bed washed, striae ironed, 6x6 restored. Take home 1. Never delegate. LASIK follow ups, do them yourself. Second, any flap complication has to be addressed immediately. Do not wait, do not observe, act. Second case, 75-year-old male, SFIL, advanced glaucoma, taken for DSEC. Graft inserted, air injected, immediately IOP started rising, AC started shallowing, pupillary block. Cannula had been directed towards the pupil, air went behind it. I burped the air, re-injected, this time cannula directed away from the pupil. Graft centered, patient did well. Final vision 6/18. Take home 1. Cannula should always be directed away from the pupil during air injection. Second, minimize intraoperative handling. Every extra touch raises the endothelium. My third case, young, anxious woman, microkeratome LASIK. After the pass, I lifted the flap and saw it. A dent on the stromal bed. Suction had broken. Microkeratome took a different plane. Abort or proceed? I proceeded. Flap reposited. Post-op day 1. Cornea clear. Vision 6/6. Lucky? Perhaps. But I'll not rely on luck again. My learning 1. Bed must be absolutely dry before suction. Second, confirm suction is tight before every pass. And third, anxious patients now receive pre-op anti-anxiety medication. A calm patient is your first line of surgical safety. Complications do not announce themselves, but every complication, if you are honest enough to learn from it, makes you a safer surgeon. These mistakes changed my practice. I hope they change yours too. Thank you. Good morning. In surgical training, we are taught what to do, but what truly shapes
I'll
a
invite
surgeon?
Shubhra ma'am to please give memento to Prateek. Rohit, your talk is next.
Operating TRD in high definition with Ingenuity system. This was a case of macular TRD with vitreous hemorrhage and subhyaloid hemorrhage. After intravitreal injection, with a gap of 3 days, vitrectomy surgery was planned. This was a 25 gauge sutureless vitrectomy. So to start the case, all the 3 25 gauge ports were made through pars plana route, and then an anterior vitrectomy was done. Following which the core vitrectomy was started. After completing the core vitrectomy, brilliant blue dye was injected to stain the membranes. After this, the remaining vitreous was removed and the membrane over the posterior pole was peeled off with the help of ILM peeling forceps. As soon as we remove the membranes, the blood vessels below it start to bleed, which should be cauterized at the very moment to prevent any blood accumulation at the posterior pole. This is done with the help of 25 gauge cautery. After this, the traction, the PVR membrane over the macula was peeled. This is tissue detail mode of Ingenuity, in which we can see each and every fiber of the membrane very clearly. With the help of ILM forceps, this membrane was removed from all the 360-degree parts one by one. You can see each and every fiber which is connecting the membrane to retina very clearly with the help of this mode. So it makes the dissection very easy. So all the fibers are removed one by one with very gentle traction to prevent any breaks. Like this, the traction over the macula was removed. After this, the posterior pole was again injected with dye to stain the ILM. In such cases, it is very important to remove the ILM as well, so to prevent any further or any future formation of membranes over the macula. So in this type of cases, a wide ILM peel should be done. So in this case, the ILM was removed over the macula till the arcade, after which fluid air exchange was done. And endolaser was done to the parts around the arcade. After completing the endolaser, as there was no evident break in this case, S was injected and the case was closed. Clinical pearls in this case were: you should always adjust brightness and tint improves the identification of tractional elements in retinal folds. You can take help of dyes and tricot to visualize different membranes or vitreous membranes. Always do a controlled PVD to prevent any breaks or iatrogenic traction over the retina. And segmentation and delamination of membranes is like divide and conquer method. You should always peel under high magnification and always peel very slowly when you are near the macula, and don't forget to cauterize the bleeders. Thank you. Operating TR.
I'll invite Preeti Rawat ma'am to please give a memento to Rohit.
Welcome, Dipanshu.
A middle-aged man presented to us on a Saturday morning. He had unfortunately sustained injury to his left eye with an iron nail, which had led to a state of open globe injury with corneal tear. Patient underwent corneal tear repair and was lost to follow-up after a few follow-ups. Suddenly, one fine day, he presented with complaints of pain and redness along with diminution of vision, and to our surprise was diagnosed to have suture-related endophthalmitis. Due to poor media clarity, patient was injected with intravitreal antibiotics and steroids, and subsequently patient improved with resolution of endophthalmitis. But the healed corneal wound had resulted in a scar and subsequent formation of cataract. So once the active period subsided and there was healed corneal scar, patient was planned for optical penetrating keratoplasty along with cataract surgery. Surgery was uneventful. However, on 1 month follow-up, it was noted that the patient had a dislocated IOL, and now we were gearing up for another intervention. Patient was taken up for pars plana vitrectomy with IOL explantation and implantation of scleral fixated IOL.
The benefit is of making sclerotomies under the flap is that you make 2 less sclerotomies than the usual 5 port sclerotomy for SFIs. cannot suture sclerotomies them because we will be suturing the flap. Three piece. IOL was implanted. Sclerally fixated. Both the hydatics were exteriorized at 3 and 9 o'clock.
Alas, the patient gained a vision of 6 by 36 at the last follow-up. Credit goes to the patient who had faith in us and was determined to get good vision.
Thanks for watching.
Very dramatic presentation, Dipanshu.
I took the word film very seriously.
I'll invite Jethani sir to please give a memento. Next we have Dr. Nupur Dubey.
A 13-year-old girl with suspected Marfan's came with both eyes advanced keratoconus. Severity of keratoconus was more in left eye, as thinnest specky was just 182 microns and there were areas of deep scarring in aosicity, groove and peeled alk in left eye was planned. Coming to surgery. After initial partial thickness trephonation, a lamellar pocket was created with crescent knife, a side port incision was made and the sides of the pocket were enlarged using blunt corneal scissor dissection. As this technique avoids very sharp instrumentation in the center, there are no chances of central perforation in the cornea which are more difficult to manage as compared to peripheral perforations. Spiraling groove continues all around underneath the trephonation edge. Once the groove reaches the starting point, the dissection spirals into a deeper plane, or a deeper plane can be found using crescent or a side port blade. For second layer dissection, the process is repeated using crescent knife and a blunt corneal scissors. As we go deeper during the dissection, we need to be more careful with the instruments. Anterior chamber should not be too tight and aqueous can be released through side port incision to avoid perforation. The process continues until 2 to 3 rounds of dissection are complete. The stromal island can be trimmed for better visibility during the dissection, and here the dissection of second layer is complete. During dissection, when the shiny pre-decimate layer is encountered, it is considered the end point. So, for dissection of the third layer, a deeper plane was found using side port blade and crescent knife, and dissection was done using blunt corneal scissors. Aqueous was released through side port incision. Once 2 to 3 clock hours of pre-decimate layer is exposed, the stromal fibers can be easily peeled off using the stretch forces distributed over a larger area. But during the last layer dissection, the unthinkable happened. A small perforation was noted. As the perforation was small and peripheral, we decided to continue with DALK and not convert to penetrating keratoplasty. The central stromal island was peeled off the decimate layer carefully using counter traction with the forceps. We decided to leave a small island of posterior stroma superiorly near the site of perforation to avoid its enlargement and also to provide some tamponade over the site of perforation. Now coming to the graft preparation. DM is peeled off and corneal button is prepared using disposable trephine. The donor is placed onto the host and sutured with 10-0 nylon interrupted sutures. First, 4 cardinal sutures are applied, followed by the rest. We need to be careful while passing sutures, as DM microperforations can occur at this step. The sutures are buried on the donor side. Air bubble was released up to around 50% and BCL was applied. Post-operative uncorrected visual acuity was 6/9 at 2 weeks. So the take-home message is that groove and peel DALK is a predictable and reproducible technique with a short learning curve. Technique is suitable for very thin corneas or the condition where big bubble is not possible, and it's possible to get good visual outcome in properly managed perforations in DALK.
Thank you. I'll invite Ulka ma'am to please present Nopal with a memento. Next video is Next video is by Dr. Nihar.
Nihar is not there. It was supposed to be a film festival with Oscar with popcorn and beer, but my budget was cut down. So I had to incorporate it in this session. Nonetheless, he submitted long ago, so we decided to play his video. It will not be for judging. And let's play the video.
Cataract. Navigating cataract surgery in transplanted eyes. Today we'll be learning how to tackle cataracts in post-penetrating keratoplasty eyes. Here are some considerations before the surgery. Always manage patient expectations before the surgery. The aim of the surgery is to protect the graft. So we'll start with the first case, a 39-year-old female who underwent penetrating keratoplasty for a post-herpetic scar. She was an anisometrope with high myopia in the operated eye with an astigmatism of 10 diopters and an IOL power of plus 1.5. Moving on to the case, we planned the incision between sutures to minimize dehiscence. After careful staining of the anterior capsule, a capsulorhexis was performed and gentle hydro procedure was done. After adequate rotation of the nucleus, endothelium was recoated with dispersive visco and the phacoemulsification was started. Ideally, a direct chop would be preferred to minimize the CDE, but I went ahead with a stop and chop because I am more comfortable with that. Recoating the endothelium with OVD can be vital in protecting the graft. Gentle removal of the cortex was done. The patient was left aphakic and the side ports were hydrated. As this was my first post-PK case, I decided to suture the incision just to make sure there are no loose ends. The patient was comfortable the next day with a visual acuity of 20/80 parts. Moving to case number 2, a 60-year-old female with a post-fungal keratitis therapeutic penetrating keratoplasty. She didn't have much of astigmatism and the IOL power was 21.5 diopters. I decided to do a SICS in this case because of the large graft size. Gentle entry was done with a MVR between sutures and the capsule was stained. Synechialysis was done using an iris repositor. The thick pupillary membrane was then cut away using a Vanna scissor. I decided to do a sphincterotomy in this case. Other options are the use of iris hooks or a stretch pupilloplasty using Pucklin hooks. A can opener capsulotomy was done as the bag seemed a bit shaky. Hydro procedure was done to achieve good rotation of the lens, which was then prolapsed into the anterior chamber by a tie rod technique and delivered out using viscoexpression. The cortex was then removed using a two-way irrigation aspiration Simcoe cannula and a monofocal rigid PMMA lens was placed. The remnant nasal cortex was removed after that. The loose sutures were removed and the incision was sutured. But the case is not over till it actually is. The IOL started to get decentered, and I realized that one of the haptic is probably still in the sulcus. I tried to centralize it, and since it was covering most of the pupillary axis, I decided not to fidget anymore because of the capsulotomy and the zonual status. The patient did well the next day with a fairly centered IOL and a visual acuity of 20-50 parts. To summarize, plan your incisions well. IOL calculation is vital. Perform a low volume, low power surgery with liberal use of OVDs and perform as minimal ablations as possible. That's my experience of the first phaco and first SICS and post PK eyes as a junior fellow. Thank you for watching.
Thank you everybody for being here. So there's an exciting announcement. We have apples and pods separately for all our speakers. Apple pods today for all the speakers, which are on the way. So you can collect it in a while from here. And the winners for this session will be announced in the inauguration ceremony. Thank you so much. Thank you, panelists. Thank you, sir. Thank you, all the judges, for your valuable time. And thank you, all the participants, for patiently submitting and waiting for 3 months for the film festival to happen. Thank you so much. To make the rest of the announcements. Thank you.
Good afternoon, everyone. I welcome you all to the grand IDOS debate. And we'll start with our first debate. Phakic IOL or surface ablation, procedure of choice in borderline corneas. We have for the motion for phakic IOLs, Dr. Shruti Kochar-Maru, and we have for surface ablation, Dr. Achal Agrawal. So, who's starting?
Yeah. Since
So
we
have,
want to go for the practice and we don't want to look bad during the ramp walk, so we thought we'll take the charge and break the line and start the session early.
Okay.
So, Achal, is your child trained already in cornea? Because since morning you have been listening to cornea talks. So we have another, sir. We have another cornea surgeon already ready.
So she keeps asking me which surgery I have done today. My daughter, she's 2 years and she...
No, I was talking about the one in your tummy right now.
Okay. So, good afternoon, everyone. Today we'll be talking on surface ablation versus phakic IOL. Shruti versus Aanchal. So here is a 22 years old female who presented with a desire to become spectacle independent and sought evaluation for refractive surgery. Her BCVA was 6.6 with -6 diopter square, and her rest of the findings were within normal limits. This is the pentagram, and her PACI was 527 in the right eye. And in the left eye, it was 528. And residual stromal bed was 345 microns in the right eye and 346 in the left eye. And the percentage tissue ablation was 16% in both the eyes. So in this case, my dear friend Shruti wants to do a phakic IOL. And my choice would be surface ablation in such a case. So I basically reshape the house and you just rent extra furniture.
So I don't want to touch the house at all. I just want to add a luxury extension. Why do you want to tamper with the house? Sir, बार-बार घर का renovation करा रही है sir.
I don't have any risk of endophthalmitis because it is not an intraocular surgery at all. So I am not going inside the eye at all. I am just touching the cornea.
So how many endophthalmitis, my dear Achal, have you seen in refractive surgery? You don't get endophthalmitis. I'm not worried about endophthalmitis at present. I'm worried about ectasia. So why do you want to tamper with something which is already borderline is my question to you.
See, if we are carefully selecting the cases, there will be no corneal ectasia. Right?
So tell me, you are just gambling. I'll tell you how.
Okay.
Sir, do you have Corvus ST or ocular response analyzer? You don't have sophisticated biomechanical measuring devices as yet, right? Are you planning to buy? That's a separate thing. But when you don't know the biomechanics, what I feel is that is the hidden factor. If you don't know the biomechanics, just don't gamble with the borderline cornea, is my point.
I know, Shruti, tissue preservation matters, but minimal ablation may still be done safely in carefully selected cases.
So are you 100% sure that there will be no postoperative ectasia in this
Yes,
case?
because I am selecting my patients very carefully.
But why not go for something very safe, which is reversible, which can, a phakic you can remove, add, exchange.
But saying reversible doesn't make it risk-free. So after overall, it is going to be an intraocular surgery.
But my surgery is definitely going to give a better quality of vision, right, ma'am? Ma'am will say, ma'am, please, you have to support this side. Phakic IOL definitely has a better quality of vision. Everyone here will agree.
No, but see, it's an intraocular surgery, so there is always a risk of cataract formation, endothelial cell loss, pigment dispersion, angle crowding, glaucoma.
And haze?
Haze, we can still manage.
You can manage haze?
Yes.
But I cannot manage my IOP rise, you're saying.
Yes.
All right. So tell me, what will you do with the dry eyes, Achal?
So, dry eye is usually temporary. So,
I have zero. No dry eyes with my procedure.
So, anyways, you are going to give small incision as well. So, even after, good IDOS, trifocals, after cataract surgery, people say that, chuban ho raha hai. So, that component may still be there because you are still cutting some corneal nerves.
You are cutting the corneal nerves. I am preserving all the corneal nerves. I am not tampering with any corneal nerves. All right. So I think I am loudly and clearly saying when the cornea is shouting, I am borderline, let's just not jump and burn it, is my point.
So, see, all said and done, there is so much stress and a lot of headache because we have to monitor the patient lifelong. We have to check IOP, vault-related complications, all these things we have to take care for the rest of the life till there is cataract formation. And then afterwards you'll say, now we have to remove this lens and we have to put some other lens. So, I think not fair.
Not fair. So, can we have a poll here in the audience? How many would like to want a phakic IOL here and how many would go for surface ablation? Surface ablation, please. Oh, I'm heartbroken. No phakic IOL at all. So, but I feel that in a borderline cornea, the safest option is always a phakic IOL. When you don't have any sophisticated machines in your setup, you should not tamper much. But there is no right or wrong, of course, Achal.
Yes.
That part I agree with you.
Yes. Because what happens is in a borderline cornea, if we carefully select the patient, we can do justice to the patient. And there is, as you said, there is no right or wrong thing. It is the patient selection which matters. And if it is a high power, then we can, yes, safely go for phakic IOL as in,
yes. So basically we are not competitors. That is the disclaimer I want to give. And neither is the refractive surgery.
Yes.
Versus phakic IOL. Both are complementary to each other. It's just about that patient selection. And in the end, I would like to say that no one is winner here, but it is finally the patient. If it is the patient who is not cleaning the spectacle in the morning and is getting the good vision without complication,
yes,
that surgery is the best. Thank you so much for your patient listening.
We have been doing refractive surgery, but as the refraction is -6 and some cylinder, regression is one of the problems which might patient have in next 5 or 10 years. So, I mean, that point goes against the cornea-based surgery. And of course, phakic IOLs have their own limitations and complications. So, I think case selection, proper counseling, and matching our treatment with the expectation of the patient. That is very important. But I mean, -6 है उसको और अगले दिन उसको यदि फेकिक आयोल करो चाहे वो करो, तो the world changes for him.
Yes.
So my protocol would be for higher order of myopia, maybe 6 or 7 phakic IOLs are more suited. But again, this is a borderline case. So there is no yes or no for this case. But again, good presentation by both.
Thank you so much, sir.
Thank you, Dr. Shruti, Dr. Anchal, for your excellent presentations. And I now request Dr. Satish Premchandani, sir, to hand over a memento to Dr. Shruti Kochar. Satish sir, please stay. Dr. Anchal. Next, we have a very interesting debate. Toric IOLs versus corneal astigmatism, the ultimate astigmatism show. For toric IOLs, we have Dr. Suhas Bande, sir. And for corneal procedures, we have Dr. Satish Premchandani, sir.
Slide. Good afternoon, all.
You got a slide, na?
Sir got the slide, I think.
Yeah.
Sir, that's the thing.
Yes.
I have been parachuted over here. Shreya was to give the talk.
Sir,
We love your spontaneity. Thank you for joining us at the end.
I don't know how much justification I'm going to do with this.
Both our speakers are in no need of any slides. They have years, decades of experience. And we hope to see a productive debate here.
So, can I start, Satish?
Yes, sir, please.
So, I should ask the audience, how would you... What would be your preference for a toric IOL or corneal procedures? For toric IOL, please. Hands on. Yes. Please raise your hand.
The question should be whether the patient is faking or non-faking. Basically, the first question should be there. Then comes a question mark. If we have to do a corneal based procedure or whether we have to go for a toric IOL. So people blindly say, yes, toric IOL. अरे भाई patient 25 साल का है, क्या करना है?
No, we are talking about management of corneal astigmatism in a patient of cataract.
Okay. But the topic heading was just not like that. We are talking about only cataract.
Cataract, hey.
Okay. Presumed cataract.
So just a case scenario here that we have a patient of cataract having an A scan, biometrical A scan done, having an astigmatism around 3, and what would be your choice of procedure? Either you would be going for a cataract surgery with a toric IOL, or we want only corneal incisions to take care of the astigmatism. That I understand.
So you are talking about the relaxing incision, steep astigmatism?
No, I don't know about any corneal surgery procedure for astigmatism control.
What is your plan over here? You are going to put an toric IOL.
Toric IOL.
Why only toric IOL? Not other any option?
No, there are options.
Have you heard about bioptics?
Yeah. So
what we do in bioptics?
So I am talking for toric IOL. So I will be speaking on toric IOL.
No, but what we do in bioptics?
Yes. You have to.
Yeah, in bioptics, what I am going to do, all your misalignment of the toric IOL, I am going to correct it with my corneal procedures.
So it would be a costly affair.
No, not costly affair. So what I can do, if it is your case, definitely I am going to charge him very heavily. So because I am going to correct all the aberrations and all the misalignments what you have created in your case. Now, if it is my case, then what I can do, I will go for a monofocal. I will not go for this toric IOL. Right. Then I will correct all kind of aberrations, and thanks to the IDOS, which gives all the correction of all the aberrations, all the residual errors, all the surgeon-induced astigmatism. So I can do. So how you can compete with that particular procedure?
No, I would also have to don't give a big bill to the patient. So for me, a cataract patient having corneal astigmatism, pre-existing corneal astigmatism, a toric oil is the lens of choice, which is very predictable and which is giving the best uncorrected visual acuity, and there is no regression, and a long-term stability is there. So patient would be happy getting a toric oil, which may be of an Indian company also. So the cost factor as well as the quality of vision both would be better.
So what is the chances of rotation? What is the incidence of rotation?
Yeah, there are surgical techniques where you can prevent the rotation. Just rotation may happen, but if it is more than three,
what is the incidence?
Yeah, it is very low. Very low.
How much?
No.
How much?
In my hands, no patient has any rotation which has to be realigned.
Maybe you are a great surgeon, but all those people who have reported the incidence, they are given from 1.6 to 3.3%.
No, then we have to ask them.
Sir, you said you did not prepare. You are answering like a pro with all the percentages.
Yeah, you know,
कभी भी खड़ा कर दो.
otherwise also I am academically very sound person.
So
don't take it in that.
So you have to ask those people, those surgeons, that why there was a rotation. There might be some faulty technical step in their surgery. If they have not removed all the viscose from their posterior chamber and there was some visco there, then there are chances of rotation. But if all the visco is cleared up and the lens is tapped over the posterior capsule, the good lenses, all are good lenses, Indian and imported one, there are less chances of rotation. And if unfortunately rotation occurs, there are now formulas, online formulas where we can have the fix it that rotation.
So you are ready to do the other procedure also?
If needed, which is very, very less chances.
Okay. So agreed to that. But what I wanted to say, if I had a patient like this, what I will do, I can give a incision at cornea also and want to reduce it by that. If I don't go for the bioptics, and if I want to go for bioptics, what I will do, I will just prepare a flap of the patient and then wait for a few days, at least 2 weeks, then go for a cataract surgery. And after doing a cataract surgery, putting a monofocal or a multifocal, whatsoever type of ad hoc lenses, I will wait for 4 weeks more and lift the flap and again do the ablation, so that I will correct all the surgical induced astigmatism plus residual astigmatism also, plus with the new machines, all the kind of aberrations from cornea to the retina, all kind of aberrations can be taken. So now the goal has become that you have to give the best type of a vision to the patient. Now even we are doing Contura, we are doing all the LASIK, but now this IDOS has come and people are running for that IDOS. Why? Because they want to use the best potential of the retina for the vision.
Patient भाग जाएगा, वो बोलेगा बहुत costly surgeon है ये तो.
So nowadays अभी
नहीं, corneal incisions के अंदर there is a problem that immediately you may get vision, good results of the astigmatism because there is no fixed nomogram. Everybody has to calculate what is their own nomogram, and then there is a regression chances. It depends on the healing of the cornea, and so it is variable, the correction in the astigmatism.
So that applies to the IOL also?
Why?
Surgeon variation is there?
No.
If you are to any consensus, sir,
if you are a good surgeon, you are doing a good phaco surgery, you can immediately go for a toric oil.
I request the panelists for some settlement here. Not reaching to any consensus.
मैं आया इधर. So I think I can give a walkover because I have to be a jury over there on the second.
Again, it is a complementary procedure. No procedure is the best. So this has to be complementary.
It differs from patient to patient always. As you say, people are saying that if the cornea is thin, we have to go for the toric. If the cornea is sufficient and the cylindrical power is less, we go for the enhanced procedure like Satish Premchandani. or if it is very high, we have to go for the toric. So it is both the procedure in different situation, they are quite okay.
Huge round of applause for this wonderful show. Ma'am, please come. Do the honors. Thank you. It's not a walkover. You know, but that doesn't mean we have reached a consensus.
नहीं कोई
Really enjoyed the debate. Thank you.
आप आ रहे आप कौन है इधर आज गुड आफ्टरनून एवरीबॉडी
We'd like to invite our next speakers for today for the topic KXL in thin corneas, to do or not. We have for KXL Dr. Prashant Bharti sir, and against KXL Dr. Ankit Devkar sir. So please.
How many
He's very
5
senior.
years
He's very senior.
5 years यार
ignore that fact completely.
I
5 साल ही सीनियर हूँ मैं कौन सा उम्र थोड़ा ना हुई अभी
मेरी क्यों उम्र बढ़ा रहे हो सर
So the debate has begun.
yes
exactly.
Good afternoon everybody. The topic very specifically is thin corneas. Would we do KXL or not? So as a disclaimer, we will say that we both of us found out that this thin cornea is also there. So we were actually going to fight against CXL and KXL in normal corneas, but we will still like to fight it out. I am for cross-linking in thin corneas also. I would just like to know from our seniors, how thin would you consider as thin, sir? Sir Aditya sir, would you in any particular? No, for you do CXL. So where is Achal? Achal, how much thickness would you say is thin for a KXL? Below that you will not touch. Okay.
So,
and 350 you will touch.
So
Yes.
basically, you know, thin cornea is a relative term. So you cannot coin it as a single digit key. A particular 350 or 320 or 300 or 400 is a thin cornea. So it has to be a relative. You have to think in a relative way, because if you do go for a CXL in thin cornea, there are many problems which can happen. So as you must be aware that there is a progressive thinning in patients. Already if the patient is 300 or 350 micron, there will be progressive thinning in the cornea, which happens over time, over a period of 1 year. And that can be detrimental, even cause increase in irregular astigmatism. Also, there is a risk of endothelial cell loss and eventually corneal decompensation.
Yes, that is true, but not all thin corneas are not KXL-able. You have newer techniques now in cross-linking where you can actually do a really thin cornea. The aim is to actually cross-link the anterior two-third of the cornea. So if you have a thin cornea, if you can cross-link that, you can actually prevent a progression and you can save him from going for a DALK in the immediate future. But as I agree, a case with thin cornea will actually need a DALK. But if his other eye is good and you don't intend to do a DALK in this eye, then probably to save him from progression, especially if he is young, I would still go for corneal cross-linking, even if there is this risk of endothelial cell loss, progressive thinning, where even I have a patient which I just operated for DALK, where I had done a cross-linking around in 2016.
So what is the PACI of that patient?
When I did the C3R, it was around 380 microns.
Okay.
And today, I mean, when I operated for DALK, the patient had a bare descemet, there was stromal lysis. There were other causes for that also. The patient was 28 when I saw now. And when I did it, it was around 22 or even lesser, I think.
So
yeah, please.
So basically, there is a study which by John Kanellopoulos, and which states that if you do a CXL in a patient who has a PACI of less than 370, the risk of failure of CXL is around 30 to 35%. That is way higher as compared to what it is. So basically, you need to have a cutoff, that arbitrary cutoff around 370. Below going, if you go below it, there are protocols like contact lens assisted C3R is there. There are hyposmol protocols are there, but the outcomes are not very encouraging, because they also have quite high failure rates. So if you go for, what you can do in thin cases is, if the other eye is normal, good vision, you can give the patient a mini-scleral contact lens, make him see through that eye, and then maybe if at all it is needed, you can go for a DLK in that patient as well.
Yes, but giving a scleral contact lens in high ectasia sometimes also causes stromal lysis and can cause further thinning. So I would actually do a cross-linking, and if he thins, then probably I will do a DALK rather than wait for it to happen spontaneously. There are, like you said, there are protocols. One of them is contact lens assisted protocol. The other one, which reduces the fluence, is a very good protocol. It's given by Hafezi et al. And I agree, for most regular corneal persons and for general ophthalmologists who are doing cross-linking, I would say the cutoff should probably be 450 microns, because if you are doing an epi of C3R, you are removing 50 microns from the top, and then you are doing on a 400 microns cornea, which is the cutoff given by the initial proponents of this cross-linking, because 400 microns they came because below that the damage to the endothelium is more. But then you can prevent the ultraviolet light from going down up to the endothelium or to the lens by adding on either a contact lens, which can reduce the intensity of the ultraviolet, or you can actually reduce the fluence of your machine. And you can also modulate the time, and it can be done in a safe pattern.
So my question is, if a patient has a 320 micron cornea, would you go for a CXL in that patient?
If the age of the patient is less than, say, 24, 25, and if the other eye is also not of the same type, I mean, if the other eye is actually very good, then I would just do a C3R in this eye and leave it, because the patient is visually rehabilitated anyway with the other eye. I will do a C3R so that this cornea does not progress, because the patient is in an age where it can progress. I will do a protected C3R and leave it as such. If the both eyes are thin, then probably I will not do a C3R. I will go for a DALK straight away.
Yeah, so basically the patient should also be then counseled, and you would need a second procedure like DLK in that case.
Yes.
And also it would add to economic burden to the patient as well. You're doing two procedures.
Absolutely right. Absolutely
so you can
right.
go for a single procedure like DLK in the first go, and maybe rehabilitate the patient in a better way.
So I think the take-home message which both of us have tried to emphasize is that thin corneas is possible. Cross-linking in thin corneas is possible, but you will have to individualize. Cost factors also will have to be taken into care, and obviously the complications will have to be taken into care. I think you agree, sir, or anything else we want to add?
I still agree that
Madam wants to
should avoid
say
CXL.
something.
I want to add something. The principle is that a thin cross-linked cornea, suppose 370 cornea, which is cross-linked, it's much better than a 470 cornea, which is uncrossed. That is the principle. Second thing is that what we are talking of is cutoff. Okay, that cutoff we are talking with the epithelium. Now, what happens in keratoconus? There is a cone. So over the cone, there is a thinning of the epithelium, but around the cone, there is a lot of collection of the epithelium.
Thickening.
So there is a thickening. So it gives you the donut pattern.
Donut pattern.
Right. So you have to do a epithelial mapping, and you have the option of stromal mapping also now. So it removes the epithelium and tells you how much is the residual stroma. And then depending on the thickness of the residual stroma, you can decide. But yes, whenever there is a possibility of doing a cross-linking, it is always better to do cross-linking, because that is in a way a non-surgical option. So wait for progression. If there is no progression, 370 cornea remains to around 370 or 360. You can visually rehabilitate till there is no further thing. the melt what you are talking about is not routinely seen in any case. A particular case, because of some
No, this patient had bad allergies also and didn't follow up for maybe last 5-6 years or so.
bad allergies, bad ocular surface, recurrent inflammation.
Ocular surface inflammation.
All these things had to.
Yes.
So that is very important.
Sure.
Thank you
Thank
so
you.
much for the wonderful takeaway message from your unprepared talk. Sir, बोलिए तो चल है ना session करेगा sir आज. Thank you so much for the spontaneous, excellent discussion. Thank you.
Thank you.
I request Dr. Ankit to stay back for the memento. I request Dr. Mohita ma'am to please give the
So we'd like to invite our next speakers for today, Dr. Bhagyesh Puri sir and Dr. Shirali Gokru, for the topic droopy lid dilemma, suspend or sling. Dr. Bhagyesh sir will be speaking for frontalis suspension and Dr. Shirali will be speaking for the sling surgery.
No, there is a little mistake in the printing. The ptosis surgery is being currently by two different techniques. The traditional technique is frontalis sling suspension by silicone rod, and the newer technique is frontalis flap advancement. So that should be correctly read as frontalis flap surgery.
Okay.
Yeah.
So let me start. Okay. So I will be speaking for the frontalis flap advancement surgery in severe congenital ptosis. Indication, as we all know, the ptosis is classified into three categories: mild, moderate, and severe, depending upon the levator function. This is indicated in severe ptosis, congenital origin, with a low levator function that is less than 5 mm. Many other indications are also there, but preferably it is done in congenital ptosis of severe type. Procedure, the little differences in the procedure of this type of ptosis that differ from the sling surgery. First of all, we give the incision on the lid crease. The whole 30 mm incision is given on the lid crease, and dissection is carried upwards towards the orbital margin. On the orbital margin, we give incision on the insertion of the frontalis muscle, and anterior to that, between the skin and frontalis muscle, we proceed to prepare the flap of frontalis. The principle behind this is, instead of taking our tarsal plate to the frontalis muscle by the help of sling, we bring frontalis muscle down to elevate our tarsal plate. So the frontalis flap is being fashioned, which is taken forwarded, advanced downwards, and the tarsal plate is anchored to it with the three cardinal points with the 5-0 or 6-0 Prolin suture. When we form the lid height, adequate lid height, we do the standard skin orbicularis strip excision and form the good lid crease with taking bite through the levator stump. Coming to advantages, this procedure is highly advantageous over sling surgery because in the sling surgery we need a different implant that is commonly used as silicone rod implant. Here we don't need any implant. Secondly, we are facilitating our frontalis muscle and using its natural power to elevate the eyelid. So it is highly physiological surgery, which I believe. And thirdly, the cosmetic outcome and the chances of residual ptosis, which we commonly get after sling surgery, are highly less in this type of this category of ptosis surgery, that is frontalis flap advancement. Now I'm very this is my favorite surgery since last 6 years, which I have abandoned doing sling surgery since last 6 years. But still some disadvantages are there that I want to point out. First is lag of ophthalmos, which we get after this surgery, is quite large as compared to sling surgery. Second, we cannot perform this in bilateral congenital ptosis. Of course, we can perform, but that becomes a very tedious surgery. Third is long learning curve. I myself took almost 3 years to get acquainted, not I can say mastering, but acquainted with this surgery. And in the initial stage, I do got some under corrections. I do posted some patients for the repair surgeries. But at now, since I am doing this surgery since last 6 years, I have highly confident on this of giving the results in severe ptosis surgery, which are not that gratifying as sling surgery. Thank you.
Thank you, sir. So to add on further on ptosis sling, as sir correctly mentioned regarding the indications of ptosis silicone sling are similar to frontalis flap advancement, where we do it in, of course, congenital ptosis is more preferable, severe conditions more preferable, and specifically when the levator action is poor, like sir said, less than 4 to 5 millimeters. But there are some additional indications in ptosis sling which I would say that frontalis flap is not able to do. So that is, one is in conditions where the frontalis action is little mild to moderate. For frontalis flap, most important thing is the frontalis action. A good frontalis action will help in a good ptosis correction and the movement. But for ptosis sling, since we are suspending the eyelid, we are suspending the forehead and the eyelid. So it is the suspension will take care of even a mild frontalis action. If it is there, it will be transferred to the tarsus. Third, another indication is if there is a patient who has previous failed ptosis surgeries. So in such conditions, previous failed surgeries, sling is preferable. Fourth is, it can also be done in patients who have myopathies, progressive myopathies or congenital fibrosis syndrome. I agree that in such cases, ptosis is otherwise not preferable, but of course there are patients who will have bilateral severe complete ptosis, where even a mild undercorrection is very, very helpful for the patient. So in such conditions, a sling is better because, of course, as we said, we'll come to the advantages. So it is preferred because it is reversible and easy to adjust, number one. As sir mentioned about the procedure. So procedure for sling, it is something which is known for more and more than many decades, and the standard pattern is the Fox Pentagon surgery which we do for the ptosis sling. I wouldn't go into the surgical details, but what I would like to highlight is that for ptosis sling we have a standard protocol, a universal sling surgery. So when we have a standard procedure, we will have standard results. When we talk about the frontalis flap, this is comparatively a new surgery which has come up. Of course, it was known since 19th century, but it has come into fashion very recently, and it's been last, as sir correctly said, 6 years. So it's hardly been 6 years when it has been started in India. So it has a long learning curve, and there is no single standard technique. It is more modified by different surgeons in their own way. So it is a surgeon-specific technique, and therefore it is difficult to teach and preach. So what I believe is, when we come to the advantages of this procedure, I believe what is easy to teach is easy to reproduce. Like here we are sitting, most of us might be comprehensive also practicing. There are many people who might be doing ptosis surgery and who might be willing to do ptosis surgery. So if you ask me to teach ptosis sling surgery, it's not a big deal. I can teach it and you can learn it. But when it comes to flap, as sir correctly said, very long learning curve. And the most important thing is, the more the learning curve is, and since it is a very new surgery, so I would just say something that sir is very, very senior to me and I'm very, very junior to her. But still, what sir is speaking about frontalis flap is a time-trending surgery. And I'm talking about tarsofrontalis sling, which is a time-tested surgery. So something which has tested, which has evidence, we know. We have long follow-ups, so we know what are the complications, and we also have literature how to manage it. But when we come to frontalis flap, being a newer surgery, there are very less data related to the complications and its management. We don't know how the flap is going to behave after 10 years. But when we talk about sling, we definitely know how it is going to behave after 20 years and how to readjust it. So if you ask me, there is a patient who, of course, I agree with the fact that sling comes down, it gets loosened over time. But since we know it gets loosened over time, we do a little overcorrection at the primary sitting. And even if it gets loosened and we have to readjust, it's hardly a matter of 5 to 10 minutes to readjust. But for flap, I would think, and I know that it is a very, technically difficult condition to readjust also. And otherwise, the primary surgery is also very difficult because it requires a lot of dissection and longer surgical duration, and therefore more time to recover compared to ptosis sling, where surgical duration is less. So the GA time is less, recovery is fast, the cost is less. Of course, the disadvantage is that I am going to use a foreign body. So there are foreign body related complications like extrusions can happen, infections can happen, but these are manageable things as we know about it. So that is manageable as far as I feel. So yeah, frontalis flap is definitely a very trending thing, and I would like to, learn it more and try to start doing it, of course. But till the time, I'm happy with my sling surgeries and the outcomes.
One thing I want to add that all of us have noticed the cases of severe ptosis, which are having very small levator function. They are less demanding. If we have a residual ptosis, or if we have slippage of sling in their future after say 10 years, 20 years, they are less demanding. But out of that, which are demanding cases, in those cases, we prefer to do explantation of the sling and doing frontalis flap, because that is giving the best cosmetic lid height as well as symmetrical lid crease. Both are important for ptosis surgery.
True.
So, but no, that is the right point. Acquired ptosis, myogenic ptosis, ptosis following myasthenia gravis or chronic progressive external ophthalmoplegia, some traumatic ptosis with very small levator function. In those cases, still the sling can be a credible choice.
Yeah. Wonderful.
One point, I'm so sorry to interrupt. The last point I would like to add is ki sling, even in case, patients, the younger children, maybe infants 6 months or age, where there is severe ptosis, to prevent the risk of amblyopia, still the sling is preferred, because the frontalis muscle gets developed by the age of 2 years. And until it is developed, you cannot go for the frontalis thing. So still, again, a positive, or I would say a point favorable sling is it can be done in younger children, less than 2 years as well.
Wonderful. Do we have any inputs from the panel?
The procedures are quite good, and it is the patient selection and the severity of the disease that is main countable. Okay, at a certain point when the two procedures are calculated equally, then surgeon has to decide, not the patient, which one is going to be the better. Since it is a gold procedure is a gold, but we cannot develop the new advancement or new procedures. We have to go, although it is going to be a long learning curve, but we have to learn. That's why in medicine, even at the age of 70 or 80, we used to say we are practicing.
Practice.
So it is a
Practicing,
practice,
of course.
matter of practice. So
Yes.
at her point, she is quite good, and at your new advancement, although it is time taking, but it is also good. None of the procedures should be left alone.
How much is the cost difference between the two?
Though the sling surgery includes implant, still as far as my practice is concerned, the sling surgery is costing much lesser than the frontalis flap, considering the time consumed.
Time and the GA time.
Almost I take 65 to 70 minutes to complete the surgery. Yesterday only I did one surgery of frontalis flap. So almost 70 minutes I take for the frontalis flap and 25 to 30 minutes for sling surgery. So the time taken, cost, of course, sling surgery is having lesser cost.
True.
The only complication is leg ophthalmos. Leg ophthalmos, which is there in sling surgery also, or any type of ptosis surgery.
Yes.
The leg ophthalmos will remain for a longer time in frontalis flap. So for that we have to put the patient on lubricants, ample appointments, but it get recovered in a period of 2 to 3 months. Here also revision can be possible because we have flap inside. As we are doing levator resection and maintaining the flap of levator inside. Similarly, we can do revision of this also.
Yes. Yes.
Reversal.
Yes. Yeah. And
Anybody is interested in seeing the surgical technique? I'm just now presenting my series of 37 cases of frontalis flap with a detailed surgery in adjoining hall. So you are all welcome.
A huge round of applause. Thank you so much for the wonderful presentation. And please come ahead to receive your memento. And this is actually a bravery award for her, because I called up 5 people. They rejected. We are not going to argue against poorest. So this is more of a bravery award for her. And you did very well. Thank you so much. And the life goes like that only. The juniors will learn the surgery, which is the gold standard, and the seniors should do the advanced surgery. Wonderful. Thank you. Thank you so much. I now invite Dr. Mohita. So if I start describing ma'am's CV, it will take me another session. Such illustrious career, and she's been so supportive to all the women ophthalmologists of India. And would you like to add something? Of course. And she's more of a friend.
Yes.
And a party person for me.
Yes.
Let us welcome Dr. Mohita with a huge round of applause. Thank you for taking all the efforts and traveling all the way and joining us today. Thank you, ma'am.
Thank you so much, Shruti, and thank you to IDOS for inviting me here. And today what I'm presenting is a new type of technique, which is a laser-assisted capsulorhexis called REXA. This is something which I've been working on with Appaswamy Associates for the last 2 years. It will soon come into the market, maybe in another 2 to 3 months, because it's in the final stages. And this may be the next big thing in ophthalmology in cataract surgery, because since this is indigenously made by an Indian company, it's likely to be very much economical compared to any other such technology which may be available. And my feeling is that it will enter into every ophthalmology clinic. So this is the equipment for REXA. It gets attached into our own very microscope, and it's basically a laser. And on the left side, you can see the console of the laser. So for this, initially animal studies were done in 50 eyes. And in these animal studies, these are the kind of laser REXs that we could obtain. Thereafter, I'll straight away go to the video showing how this laser-assisted capsulorhexis is done. It's a patented technology. Just sound weird. So this is how the laser gets attached as an attachment to the microscope. We have worked on the working distance along with this so that we have enough working distance there. And this is a routine cataract surgery being performed. The red lights that you can see, those are the focusing lights of the laser. In this surgery, staining is crucial because it's only when the capsule is well stained will the laser be taken up by the stain. So this stain is our usual stain blue dye that we use, but it's of a different higher concentration, and again this concentration is patented. So even sometimes when we find that the stain is not regular, we may re-stain it also, because as I said, it's a crucial step. The viscoelastic that is also used is of a higher viscosity than what we normally get, and again this is again a patented viscoelastic. And this has been worked out by different various permutations and combinations to find out as to where is the best concentration through which laser would penetrate. And now the magical REXs will happen. So this is on the foot pedal control, and this is the REXs that is made. You can see it is round, it is regular, it is precise, there are no tags, and the capsulorhex is margin. And the wonderful thing about it is that we can actually decide the size of REXs that we want. We can choose from 4mm to 7mm, and everything is under control. Whatever we choose, that's the size of our REXs. In this case, I have purposely chosen a hard cataract. It's done in quite a few cases in the last 2 years. I've purposely chosen a hard cataract to show you the strength of this REXs. This REXs is stronger than any other REXs that anybody would have made till now. And the reason is because it's a coagulative laser. It's one of the lasers that we use. It's a coagulative laser. See how far apart am I pulling with the two dialers, and yet the REXs is not giving way. And that's why I chose a heart cataract to demonstrate that even if when the heart pieces come out, the rexus does not give way. This rexus is suitable for all types of lasers, for soft cataracts, for all types of cataracts, soft cataracts, hard cataracts, reducing cataract, any grade of cataract. The only place where it may not be suitable is where there is a fibrosis of the capsule, or where there are corneal opacities, because the laser does not penetrate well through the corneal opacities. Many of you may be wondering, why do we need this? We already do such a good rexus manually with our own hands. So yes, it is true that we do very good rexus with our own hands, and we find it almost a controlled rexus, but we cannot control the size, and we cannot be 100% sure every time that the precision is the same. And this is an era where we are using press myopia correcting lenses. We actually need exact size of rexus, and we actually need 100% predictable results. Now we know that if the capsular rexus is large, then the lens tends to come out, and which results in induction of some refractive error. And when it is small, the lens means effective lens position changes, and which can result in small residual refractive errors. And today is an era where we are aiming for exactly almost a zero post-operative result to the zero diopters. So now we have results of around 2 years, post-op results also, to see how this rexus has been performing. And along with this, we also, in this study, we have done specular microscopy also, because this is the laser. We wanted to see if it is affecting the corneal endothelium, and we found, and we have done cases such that one eye it was a manual rexus, and the other eye it was a laser-assisted rexus, and we found that the corneal endothelial counts were similar in both eyes, which means that it does not damage the corneal endothelium, which was another important consideration that we have to take into. Now the rexus margins, we have seen on electron microscopy, the rexus margins are outturned, and the capsular flap margins are interned. So it coagulates and it outturns the rexus margins a little. So probably that's the reason that there is so much of strength in this rexus that whatever you do, it does not give way and it does not get pulled apart. Just the last part, wait for half a minute more. So my whole intention of working in our hospital as a research unit, whole intention of working on this was that I feel that if it comes into the market, it is something which will be alternative to femto laser to some extent, because femto laser is something which is out of reach of most of us. So let's have something which is within reach for everybody. These are the post-op pictures. As you can see, that it's like coagulated. We used to have Zepto before, that was like irregular. It was like RF capsulotomy was also irregular, but this is a total coagulative laser, hence it is very, very strong. So there are many studies which have compared femtorexes with a manual rexes, and most of those studies have found that the results as far as post-operative refractive error is concerned are better with the femtorexes. And we want that better maybe of a very slight amount, but that's what we all are aiming at. And these are the scanning electron microscopy pictures which I was talking about, where we found that the margins were interned. All about Rexa, which is soon going to come in the market. So wait for it and start using it as soon as it comes. Thank you. Yes. As of now, they say it can be adapted to Appasamy microscope, but then they are also making an adapter which will also soon be launched along with this, where it can be adapted to any microscope. I have done in quite a few hypermature, you mean intumescent cataract. I have done quite a few. None have shown an Argentinian flap sign. In fact, this video is of a earlier version where it was taking more time. Now it's within, I think, it's much faster. It's like within a blink it happens. So, and I've not seen any Argentinian flap. Yes, hypermature with the fibrosis we can't do, but hypermature, intumescent, everywhere it has worked fine. Yes. So again, this video was initial video where we have not fixated, but now what we are doing is we are using that simple fixator that we have been using. Yeah, scleral fixator. If it hits the iris, there is a just like which happens in excimer laser. Beyond a certain point, it does not work. It stops the laser. Yes. Exactly. I don't think it's a tracker, but it stops beyond it. It has some range beyond which it stops, so it never hits the iris. All types of cataracts. It's not just for intumescent. Yes. That. Initially, we started doing it with the normal concentration of the stain as well as the visco, but the laser penetration and uptake was not that good. So it's by various combinations, permutations, combinations. But then we took step by step. We took a higher concentration of the blue dye, and the concentration where we got a perfect Rexus is because the laser uptake happens at that concentration, and then how the laser penetrates through the viscoelastic is also important, so that at that particular concentration only we were getting the optimum results. And the laser is of a particular wavelength. It's of a particular wavelength. No. It could have been modified. So there are two type of lasers of two different wavelengths we tried. And out of that also the one which was better, which showed a better and a more consistent result is, so we stuck to that and then we modulated on the dye and the viscoelastic. Not to be revealed right now as per the company. It's a similar visco, it's a higher concentration that what we use. Cohesive. I have not done that till now, but I think it can be. I think it will also require a staining again.
Yes.
It will require a stain.
If you want to do it like if you started manually and then the Rexus extend, and if you want to take it back, like these can be your future things. Like you can think of doing into various conditions where requires precision and PPC.
Yes. Thank you. Yes. That's what PPC also should go.
Thank you, ma'am.
Again, they've not revealed, but one laser that is available till now, one is femto, we all know the costs, and another is one capsule laser, which is not an Indian one. But they say that compared to that, it will be 1/3 the price. To that capsule laser, which is around 1.2 CR. Yeah, it should if we stain. Yeah, that is there. That once we've done that, I don't know. We'll have to check on the staining part, how it stains.
Thank you so much, ma'am. That was really fascinating, but a little ironical with these capsular Rexus assistance devices is that those who need it can't afford it, and those who can afford it don't need it. But really nice, ma'am. I request.
So as I said, it's for the accomplished surgeons also. It's not just for beginners, and it's for all type of cataracts for getting more precise results.
Just a humorous note from.
Yeah, I know that. Coagulation. This is coagulation. Yes, those little white you could see on the edge if you.
when we do the primary capsulotomy, posterior capsulotomy with the whatever the process, needle or whatever it is a capsulotomy.
Yes.
Here we are going to perform the capsulectomy. So where the posterior capsule residual part that we have to remove, where it will go, the membrane, because it's going to be once in a cycle, na? So it is a flap type of the things. That is
I took it out by Visco.
You took out the anterior one.
Acha,
I am talking about the
posterior.
posterior.
So that's just the idea that she gave just now. Just now, we'll think more about it. Yes, it should not go into the vitreous. Yes, yes, very logical point.
I request Dr. Sir, आपको बुलवा रहे हैं सर मेमेंटो देने के लिए सर. I request Dr. Gajen Chawla sir, Dr. Vinita Ramnani ma'am, and Dr. Kishan Verma sir to hand a token of appreciation to Mohita Sharma ma'am. Next, we have a really interesting debate. Can artificial intelligence algorithms, they are ready to take over diabetic retinopathy screening from human graders? For artificial intelligence is Dr. Tina Agrawal, and for against artificial intelligence is Dr. Mayur Rok. This is going to be interesting.
So good afternoon, everyone. Here today we are going to have a debate on our artificial intelligence algorithms. They are ready to take over the diabetic retinopathy screening program from human graders. So I'm going to talk in favor of it. So why artificial intelligence? Why we are thinking? We started thinking of artificial intelligence for diagnosing the diseases in our field. So in diabetic retinopathy, it is helpful because the India has a huge load. We have a second highest number of diabetic patients, and in that we have around 100 million people of diabetes in India, and prevalence of diabetic retinopathy is 12%, and out of that the sight threatening is 4%. So we have to screen 4 million people, and number of ophthalmologists are obviously lesser. According to AIOS, we have hardly 25,000 to 30,000. So we need something which can screen. So that's why we are here for the artificial intelligence. So here Dr. Mayur against it.
Good afternoon, everyone. So my point is that why first AI? Why not inculcate our vision center workers, our paramedical staff? Because they are not going to be the responsible ones. We are going to be the respondent superiors. So anyway, it has to pass through the doctors. Since AI cannot detect unexpected retinal pathologies, it can detect only what it has been taught. If you ask it to screen for DR, diabetic retinopathy, it's only going to look for diabetic retinopathy. It's not going to look for glaucoma. It's not going to look for ARMD. So it has kind of a tunnel vision. Another point of mine is there are a few atypical presentations which we also don't know. So how is it possible for the AI to detect and classify it? Another big roadblock hurdle why I oppose AI alone in diabetic retinopathy screening is the black box effect. So basically what goes inside and what comes outside, that is visible to us. But what goes on, the process which goes on inside the AI, what it thinks, how it processes the data, we don't know. The AI cannot tell us. If you ask the AI, how did you arrive at this conclusion? The AI is going to reply, this is my learned algorithm. The algorithm has given me this response. And if you probe it further, the AI just lies flat and tells you that I am unable to answer it at this point of time. So that's ma'am, thoda sa piche. Even though now AI, which began at 91% specificity, has reached up to 95% specificity, still it lags behind humans. Humans still outrank AI at 99%, and 5% false negatives is still a very, very big number.
Here I want to add, like we made the AI to learn in diabetic retinopathy, only the diabetic retinopathy which is more than mild NPDR. So the AI has to learn, and AI is giving the images where it is identifying any diabetic retinopathy which is more than mild diabetic retinopathy, that we call it referable diabetic retinopathy, and that reporting should be done. So the machine, there are n number of studies are available, and AI is already there in our society, in our country also. From last year, we have 3 AI which are validated for diabetic retinopathy screening. One is Forus Health, other is the Remedio Health, third is the Madhu Netra, which was developed in AIMS, and since last year AFMC has adopted, and in the recently 3 days back only, the Andhra Pradesh, they also implemented that AI system for diabetic retinopathy at district level. Rajasthan already implemented it.
Ma'am, I have 2 counters, ma'am. I agree that 3 new ones have been adopted and another new one is coming. But where's the uniformity, for which we are like, the point in favor of AI is the uniformity. But where's the uniformity when you are adopting different models in different in the same population? And another counter, ma'am, I agree that it is trained to look only for referable DR. But a 2025 meta-analysis of Ansari et al. Study, Lorenzo et al. Study, and another one I forget, sorry. So that the meta-analysis shows that there are more than 50% of the images have been classified as non-gradable by the artificial intelligence model. So that is my current. I'm not saying it won't recover, but currently those are the roadblocks which I feel.
Those are definitely there. The biggest challenge is getting a clear image, because AI can give the report on the clear image only. And for that we are working, and obviously there are n number types of fundus cameras are available. So that's why these kind of differences are there, and that we are going to learn with the future. So here the most important is the screening coverage will be obviously will be more, because here we need the optometrist or a OT technician or any paramedical staff we are training and giving them the fundus camera. Online, offline app platform is available, so they can take the images. So screen coverage will be more. There will be reduced workload for ophthalmologists. Diagnosis is very fast, because within 20 seconds it can create the image and it can get the image and create the report.
So my counters, the pitfalls are, I totally agree that AI is ready to assess screening. I myself have worked with Smart India when I was in Arvind Coimbatore. So for 3 years I have been a primary grader. But still, I would say that it is not yet ready to replace us or take over those duties from human graders. So in that same font size and the amount of highlighting that I've done, I would like to say that artificial intelligence has a role, but it is still inferior to human oversight. Ma'am, just one more click, please. Otherwise, we may end up in these kind of situations, humans versus machines. So we don't want that. My recommendations personally AI should be independent in doing low risk triage. It definitely, what ma'am said, it definitely can flag referable diseases, but the referral power should be in the hands of the graders or the supervisors. AI should definitely assess image quality and hence reduce workload for the graders.
So this is the Madhunetra AI I am talking, last year validated, developed by the AIMS, and AFMC already installed in 7 district hospital, and the same is installed in district hospital of Rajasthan and recently in Andhra Pradesh. And they had a channel, like they are first screening the diabetic retinopathy in the rural areas, and whatever the AI is giving the reports on the basis, if referable diabetic retinopathy is there, they are reaching to ophthalmologists and retinal surgeons. So thank you very much.
May I have one last statement in, ma'am? May I say, I'm definitely not against involving it, but I'm definitely against handing it over. So that's my take.
No,
so I want
obviously-
the boundaries to be black and white and never gray.
No, obviously the humans will always be watching, because here we are not talking about the treatment, we are talking about only the screening.
Yes.
And we have so many numbers of diabetic retinopathy in especially the rural areas where the diabetic retinopathy and diabetes incidence prevalence is increasing day by day.
But ma'am, humans are also becoming lazier, ma'am.
You're ragging him now.
Humans, ma'am, humans are becoming lazier by the day. Who used to say that 5 years down the line they won't say that, okay, you do the laser, I'm just I'll maintain oversight.
Maybe the time
That's why I don't-
time may come. We just need to get the patient sit
But I'll
over the
still
chair
stay
and
out-
laser will
I'll
start.
still stay out that loop. I'm
Thank
not
you so
doing
much
it.
for the wonderful discussion. Let's have a huge round of applause.
Thank you.
May I call upon Dr. Tina ma'am to come ahead and receive this wonderful token of appreciation. Sir, can you please do the honors?
Chawla sir, can I definitely.
Actually,
my
I'm working.
favor.
I'm working with this AI in DR, and probably in this session I'm going to share my data out. We have done almost 1,000 patient screening with Remido cameras. No financial interest is there. So it is definitely giving a boosting in screening. So no doubt it is AI will be there, and we have to accept it. It will be there. Yes. That grader role is practically not there now. The only thing is the grade flag, whether it is a positive for diabetic retinopathy. In Madhunetram also they are now going with DME also. They will identify DME cases also, NPDR and PDR and all that are already there. And ungradable. These patients are having the red flag, so that has to come to the human judgment. A retina specialist
For
judgment.
DME, sir,
Mazur
OCT
Etram is
images
coming.
also you are
Pardon?
combining.
Huh?
For DME, OCT images also you are
No,
combining.
no, no.
Only
I'm not.
fundus
No, no, no. We are not coming. I'm using Remido. Remido don't say about DME. Madhu Netram is coming up. They have not launched yet. So Madhu Netram, because I have spoken to Dr. Chavla, Rohan Chavla in AIMS. He is developing that. He has just shared with me last month. Okay, now that Madhu Netram will looking for DME also, and they are coming shortly in that. So AI is there. One has to. I think AI is here, and that will stay. So there will be in future doctors with AI well-versed and doctors without AI knowledge.
Thank you so much for your wonderful input, sir. Thank you so much. Can I please have you here, ma'am? Photo, please. A round of applause, please. I know we all need a tea or coffee, but still. Mayur, big round of applause for ma'am.
Switch on the mic also.
Thank you. Mayur, please come and receive this. Sir, please.
In the meantime, I would like to say only one small thing. With the coming of autorefractor, we people are forgetting how to do the retinoscope. When is the convex mirror? Where is the plane mirror?
Oh, so I don't have any slide.
I would like to invite our next speakers for today, Dr. Vinita Ramnani ma'am and Dr. Divya Patel ma'am, for the topic trabeculectomy versus MIGS for surgical management of glaucoma. Dr. Vinita ma'am will be speaking for TRAP, and Dr. Divya will be speaking for MIGS.
So basically, it is not a fight, it is just a scientific discussion because we have two methods to treat our glaucoma patients. So it's like an MIGS versus TRAP. Don't believe the hype, filtering surgery still rules the game. So Divya, be aware. No, that's why I said it's not a fight. So we know that trabeculectomy is 50 years old, widely accepted procedure, very effective, popular, safe in majority of the cases, and it is used for all the types of glaucoma. So the assessment of safety, efficacy, and cost effectiveness of TRAB over MIGS is debate. Do you want to say anything regarding Indian perspective?
Mike. So definitely, as you said, trabeculectomy is still gold standard, but I can say the MIGS is also a silver standard, and definitely there is some patients who definitely need the MIGS also in Indian scenario, and we have so many options for patients, like cost-wise also and result-wise also. So definitely MIGS is an upcoming, evolving surgery in future.
There are disadvantages of trabeculectomy, and most of them are manageable. Still, trabeculectomy really such a bad option to replace it with MIGS?
No, I can't say that is definitely a bad option. As I already said, ki TRAB is the gold standard surgery. I agree fully with you. But as we grow up in the future, so definitely it gives very bad things in few patients, which of course gives the bad result to patients' vision. So in few patients where we can't perform trabeculectomy, like mild to moderate cases, and where the patient can't put the one drop even in his or her daily life, of course MIGS is a good option rather than TRAB.
There are not enough data to change our practice. The MIGS experience is limited, and we need long-term studies to understand. And there is dearth of scientific publications and evidences and references. And not only this, there are so many MIGS procedures at various levels being noted. So do you think it is good to have all these procedures without any long-term follow-up and putting the patients on MIGS?
Although we know the MIGS, ma'am, surgery is minimal invasive surgery, so I don't think we need a long follow-up or data for the MIGS results. In few data also we can find out the results of MIGS, because it gives very much less anatomical disturbances, very much less IOP fluctuation, very much less follow-up for the patient. So of course the results are very good in MIGS. So the short data, on the basis of short data, we can perform the MIGS very well nowadays, which all makes patient very happy because of no post-operative follow-ups, no post-operative complications like in TRAB. So with little data also we can go for MIGS.
So there are a lot of hurdles in doing MIGS, and special hurdle is doing and learning the gonioscopy procedures.
But ma'am, I think the gonioscopy, it's very easy for nowadays. Everybody is doing gonioscopy in OPD. So surgical gonioscopy is not a very much big deal. So everyone can do the gonioscopy.
And what about the results? It is not very effective. It is only giving a very small good results in a chunk of a patients which are mild glaucoma. Not even to think of a severe secondary glaucomas, which are the major chunk in India where MIGS doesn't work.
Of course, ma'am, MIGS can't replace the trabeculectomy, as we always discuss this thing. But there are nowadays, because of digital platform, because of awareness, patients come to us very early signs with glaucoma. And for these patients, we can't do trabeculectomy because we have a selected patients for trabeculectomy, usually in advance or if some complicated cases. So we have a burden of mild to moderate cases of glaucoma, and we has to handle with that patient. So this surgery definitely best for those criteria of the patients.
So it is economical versus expertise, and I think it is not everybody's cup of tea to do those bang procedures and the procedures which doesn't require the implant. And in the initial stages, you will end up into doing lot of complications in bang, and lot can be a big hyphema and damage to the eye. So the MIGS has a big learning curve if you go for non-expensive MIGS, and even beside this, it has lot of complications and contraindications. So those patients which are there on anticoagulants have a bleeding diathesis, you will not be able to perform gait. So not only the learning curve, not only the expenses, but there are a lot of complications and contraindications to MIGS, which are very, very safe, and we can able to manage glaucomas like neovascular glaucomas, very advanced glaucomas, the glaucoma with corneal opacities, and so many other conditions where we have to deal glaucoma each and every day. So, could MIGS replace trabeculectomy?
Future is of course with MIGS, ma'am, because we are now playing with the angles. So of course MIGS is the only future in glaucoma, but of course we can't replace the trabeculectomy in place of MIGS because every surgery has its own cons and pros. So definitely we need in some patient trabeculectomy, but for nowadays, because of all digital platform awareness, mix is the future in glaucoma surgery.
I beg to deny, because MIGS is a totally different platform. It is not here to replace the trab, or it is not to be done in a places where the trab is required. I think it is the procedure which is going to stay, but it is there as a new surgical approach which fits into a criteria where there is a medication on one side and there's a trabeculectomy or glaucoma valves on the other side, and in between the two, you can fit into MIGS. So the debate is not right that MIGS is
Basically,
going to replace the trab,
It's
but
drug
both the
versus-
techniques will remain.
It basically drug versus MIGS, I can say,
Yes.
for the mild to moderate cases.
So which method to be used for the glaucoma treatment, it depends upon the glaucoma continuum. Whether you are treating on a very early glaucoma patient, whether you are treating a very advanced glaucoma patient, or whether you are treating a secondary glaucoma patient. So you have to individualize your patient care for the benefit of the patient, and you should be able to do justice to the disease and the patient, and you can deliver the result. If I am a good surgeon, I am doing trabeculectomy from so many years, I may not replace it with the MIGS because I have an MIGS learning curve. So why to shift? If you are satisfied with your procedure, you go on. Somebody else, a newer surgeon like you, can start with MIGS.
But ma'am, anybody can do the MIGS. It's very easy surgery, especially surgeon like you. If you are doing trabeculectomy, then of course MIGS is nothing for you. So everybody can learn MIGS very easily. Being even phaco surgeon also MIGS, I think because of new technologies and Indian scenario, cost-wise, we are introducing a new instruments, which is very good, fine, and it gives fantastic result along with the cataract surgery also. So definitely some part of patient need MIGS, of course, some trabeculectomy.
Correct. So we are not debating, we are giving you the two different perspectives with the MIGS and TRAB. Both are going to remain there. Both are required for the glaucoma treatment. That's a basic method we want, that is a basic message we want to deliver. So it's not a debate, it is both together.
Awesome. Thank you so much for your wonderful pointers. Thank you, ma'am, for your wonderful insights. Thank you. Do we have any inputs from the panel? Thank you. Now I request, ma'am, please accept our token of appreciation. Sorry, I got exercise karate, but you're the fittest person here. This is nothing. You do trekking. It's just yes, this is a mini lifetime achievement receiving from the president. Dr. Divya, can I ask you to please come ahead and receive this, please? A round of applause, please. Wake up, wake up. All right. So before we move on to the retina session, we have a Dhurandhar surgeon with us here today. Dhurandhar. So please come ahead and show us the video you wanted to show us previously. Just few minutes from your session, if I may steal. Thank you so much. Sorry to keep you waiting, sir. Divakan sir, we welcome you here to Indore. Just 5 minutes.
5 मिनट मतलब भगाना पड़ेगा 5 मिनट मतलब भगाना पड़ेगा कर देते थैंक यू
So much fun to keep retina people waiting. Strange joy in troubling retina people. Just 5 minutes.
किसने किया था अपने सेव नाम तभी तो कुछ होना नाम बिना नाम के मैंने यहीं पे किया PHACC नहीं ये नहीं नहीं ये नहीं नाम चलो इसमें लगा दो इसमें लगा दो इसमें लगा दो
Can I request Ayushi meanwhile to call upon the panelists of the next session so that we save some time here?
First one.
Ayushi, come on, you can do it faster. You're calling still?
Good evening all.
I request everyone in the hall to be please seated so that we enjoy the video here.
Just because two sessions collided at the same time, I missed the video presentation and respected Chairman Scientific Committee and Scientific Committee has accepted my request to present on this podium. Thank you so much. Yeah, please play. Lights on. So, here is my experience on intelligent suspension of 37 cases. That is based physiological, it's going long and we can create a dynamic. So it has a long learning curve, long physical cycle, difficult to benefit the problem. So here is a series of 37 cases of mental and advanced. Poor liver function arise. Is being given. We go straight away below the eyebrow for the mental muscle. Now we are differentiating the levator muscle. We can say levator as well as mental muscle. Levator is very mild power inside the system for excess of frontalis flap is excised. Strip of skin orbicularis is being excised and dynamically decrease is created. Different case scenarios has been discussed in this video. This is the final outcome of the patient. We can see the comparative photograph after 6 months. Pediatric severe ptosis, coming to the pediatric counterpart of ptosis surgery. A 13-year-old boy with a severe ptosis in his left eye. Lid crease marking and frontalis flap marking is being done. Lid crease open and we are seeing the structure we are seeing is nothing but a frontalis muscle. Again, the levator aponeurosis is being dissected and we need to excise that aponeurosis. Here we always keep the levator stump. The levator stump help us to prepare a cosmetic lid crease which is symmetrical to other eye. The aim of ptosis surgery is not only giving height to the lid. The second aim is to give a good eyelid crease which is symmetrical to other eye. Third scenario is failed sling surgery. Nowadays we are getting a lot many cases of failed sling surgery in which patient demands more cosmesis, eyelid crease incision for the frontalis flap. flap is being dissected. We can see the sling. We remove that sling. The frontalis flap is fashioned and anchored to the tarsal plate with the help of 50 polypropylene suture. On table correction and final appearance. Comparative photograph after 6 months. Frontalis flap using radio frequency probe. Up till now we are preparing the frontalis flap by scissors, by blunt dissection, but nowadays we have shifted to radio frequency probe for dissection of frontalis flap. Again eyelid crease incision. All dissection is being done by the radio frequency probe. This you can see the insertion of the frontalis flap being separated from overlying skin, advanced downwards, disinsertion of the levator muscle, removal of the levator, proximal end of tarsal plate is being cleaned up to reinsert the frontalis muscle. A dynamic eyelid crease formation with the help of stump which we have left of the levator muscle. The cardinal sutures are being applied at the 3 points to give a good lid height. Excess of frontalis is excised. Strip of skin orbicular is excised to create a lid crease. This surgery may take 60 to 70 minutes to perform. Pre-operative photograph, and this is post-operative outcome on day 15. Coming to the last case, ptosis with the double elevator palsy, in which we have to do elevation deficit first with the help of IR recession. After IR, you can see the downward displacement of the globe, downward deviation of the globe, which is corrected by IR recession first, and then patient posted for frontalis flap advancement surgery. Flap created and cardinal points. Strip of skin orbicularis is excised. And the dynamic lid crease created. Pre-op photograph, and this is post-op after 3 months. These are some more results in different age groups. Thank you so much.
Sir, wonderful presentation. Sir, I have 2 questions for you.
Yeah, sure.
So one is, when we are dissecting out the LPS, so
Yeah.
sir, what is the extent till the white line?
Yeah, we have not white line, till the Whitney's ligament. We have to dissect the LPS.
And beyond it, that stump you leave from where the muscle.
Yeah, Whitney's ligament we have to retain.
That you retain.
Yeah.
And sir, another thing is, you have taken a strip of orbicularis in all the cases.
All the
but sir, already इतना leg ophthalmos हो रहा है, तो फिर orbicularis shortening और क्यों?
Actually, the reason behind leg ophthalmos is anchoring of the tarsal plate to frontalis muscle and not the skin.
But sir, that will also further, orbicularis shortening भी तो leg
No,
ophthalmos
but every ptosis surgery should include skin orbicularis strip
तो
excision.
सिर्फ जितना excess है, थोड़ा सा strip that you remove for the lid crease formation?
For the lid crease
Neater,
formation.
For the neater one.
Yeah.
Okay. Thank you, sir.
Thank you. Hide the photograph. Yeah. I take the utmost care to hide the identity, but in video some overlap will be there, and that's why that is necessary. Nice suggestion. Thank you.
Thank you, sir. Thank you for that video. Now, now we are getting into the retina session of this conference. And as chairperson of the session, I would like to invite Dr. R.K. Agrawal sir, Dr. Bhaskar Buranpurkar sir, moderators Dr. S.K. Parwani sir and Dr. Gajen Chawla sir. Sir, please take your seat. And for panelists, सब है सब है पहले नहीं सचिन सर सभी पैनलिस्ट में तो actually since retina session the theme of the conference is cataract and glaucoma, so we retina sessions are in minority in this conference. So actually all the audience in the question are very delightfully invited to be on the panel as well. So if you are comfortable at your seats, you can give your opinion there only, but everyone in the audience is a panel. And I would like to warmly acknowledge the presence of Dr. Divakant Mitra. He's a national faculty here for today, and he has come from Lucknow, and he is a very dynamic, well accomplished, well into research and academics, and one of the pillars of Young Ophthalmological Society of India. Welcome, Dr. Divakant. So for the first talk,
Good evening, everybody. I welcome you all to this Retina Reality Redefined session. I will extend a warm welcome to our chairperson, Dr. R.K. Agarwal and Dr. Bhaskar Burhanpurkar. And all the panelists who are present here, I welcome them all. The first talk today is Retina Checklist You Must Not Skip Before You Do the Cataract Surgery by Dr. Sachin Burhanpurkar. I invite him to present his case.
Thank you so much, sir, and IDOS for giving me this opportunity. Actually, I thought this presentation was more for cataract surgeons, but here I think most of all of us are retina specialists. So let us go ahead. My topic is retina checklist you must not miss before cataract surgery. So cataract surgery is the most common procedure surgically done throughout the world. Cataract surgery is not just vision improvement, but it has gone one step ahead to refractive cataract surgery. So the patient's expectations are very high. The condition of the retina directly determines the final vision. So fundus examination is imperative for all cataract surgeons also. So before moving on to the retina checkup, one should do a proper anterior segment checkup also. Any patient with high refractive error, small or large bulging eyes, squinted eye, band-shaped keratopathy, iris coloma, iris nodules, post-synechiae, keratic precipitates, uveitis, deep or shallow anterior chamber. All these patients, you should always try to do the proper posterior segment checkup also. So basically you should be able to find out the retinal pathology and do the management properly for documentation and patient understanding. So what are the modalities for retinal checkup? First, most important, indirect ophthalmoscopy, OCT and OCT angio, wide angle imaging of photography, B scan, angiography, and VP. So direct ophthalmoscopy in this today's time, everyone should be very well acquainted to it with either 20 diopters that can give you a full idea of the retinal periphery as well as the central parts, and for the macular area 90 diopters and 78 diopters. So this is how a normal fundus photograph would look. The smooth orange red background with clear dark red center, smooth continuous lines of the blood vessels, sharp pink and bright pinkish white margin of the optic disc, and no other leakages or deposits seen. So OCT and OCT angio, they are non-invasive painless imaging tests that can really give a very good idea about all the layers of the retina, and the angiography can enable non-invasive visualization of the blood flow in the retina and the choroidal capillary network. Angiography still holds its own importance, especially in diagnosing ischemic vascular pathologies like advanced diabetic retinopathy and vein occlusions. B-scan ESG is an important tool in advanced cataract cases where fundus is not visible, basically to rule out RD, vitreous hemorrhage, posterior staphyloма, intraocular foreign body, subluxation, and in pediatric cases for congenital and acquired disorders. Fundus, since fundus is not directly seen, so it is not possible to detect all the retinal pathologies. Hence, prognosis should always be explained in mature cataracts. Then excellent newer modalities for busy ophthalmologists or those who are not well versed in direct ophthalmoscopy, the wide field imaging tools that can give very good idea of the whole fundus as including the periphery. So what are the common posterior segment pathologies that may be found in cataract patients? ARMD, high myopia, macular hole, ERM, RVOs, diabetic retinopathies, optic atrophies, VMTAs, uveitis, CME. These are, I mean, just to name a few retinal pathologies that may be seen in cataract patients. ARMD, obviously, since most of the patients are aged patients, you can have a dry ARMD or wet ARMD. Dry ARMD, nothing to do, no intervention required. But explaining to the patient is very important. If there is a membrane, you have to give an anti-VEGF injections. Multiple injections have to be given, and that has to be explained to the patient. Either you can do it before the cataract surgery or during the surgery. Retinal detachment, large detachments is easy to diagnose, but shallow RDs may be missed at times. So patient has to be managed on a priority basis, either with vitrectomy or scleral buckling. They can be done as a combined procedure or a separate procedure. The post-op ifs and buts should definitely be explained to the patients. Then we can have retinal vein occlusion patients, both BRVO, that's a branch retinal vein occlusion, or a central retinal vein occlusion. If there is associated macular edema, anti-VEGFs have to be given. Explain to the patient properly. Preferably wait. Ideally, one should wait for the edema to subside and then go ahead with the cataract surgery. Post RVO, after 3 months, angiography must be done to rule out ischemia, which may require laser. It is also important to rule out glaucoma, and patients may develop neovascular glaucoma in the later stages. That has to be explained to the patient, especially after cataract surgery. High myopia patients, again, there is a surgical challenge for surgeons, a challenge for surgeon as well as patients. It may be associated with macular degeneration, peripheral lattice tears or holes. The lattice or the holes or tears must be treated with prophylactic laser barrage before going ahead with the cataract surgery. If there is a myopic membrane, anti-VEGF has to be given, and the risk for post-operative RD and vitreous hemorrhage also should be explained to the patient. Again, high myopics may have a posterior staphyloma. Macular hole, either in the form of lamellar hole or a full thickness macular hole. Again, prognosis has to be explained. Nothing to do in the lamellar hole, but full thickness may require, it requires surgery. That can be done in the same sitting or separate sittings. Epiretinal membrane or VMTS or vitreomacular adhesions, leave it to the retinal surgeon to decide what to do. Traumatic cataracts, look for subluxation, zonular lysis, peripheral retinal tears, capsular damage. It may or may not be associated with foreign bodies. The prognosis should be explained. It should be well documented on B scan, X-ray, CT scan to rule out foreign bodies. Coming to the most important, diabetic retinopathy. With the increased number of diabetics, what are the problems faced with such patients? It may cause post-op macular edema, worsening of PDR, induced vitreous hemorrhage and TRD. Half-treated or untreated PDR may cause neovascular glaucoma, and also there is an increased risk of endophthalmitis in poorly controlled diabetics. So it is always better to diagnose the diabetic retinopathy and try to find out what are the.
Please conclude.
Yes, sir. Proper intervention is a must in all diabetic retinopathy cases. Special reference to OCT biomarkers like ISOS disruption or external limiting membrane disruption, DRIL, serous retinal detachment or large cystoid macular edema spaces or hyperrefractive foci. All these conditions, the prognosis is even further poor. Uveitis mainly needs steroids, and there is a high chance of developing of cystoid macular edema that should be explained to the patient. Pediatric cataract cases may be associated with multiple retinal pathologies like PHPV, ROP, RD, ocular toxocariasis, retinoblastoma, Coats disease, retinal dysplasias. Prognosis should be explained very well in RP, retinal dystrophies, optic atrophy, post-CRVO. In mature cataracts, B scan should be done in all mature cataract patients. Rule out amblyopia. and you can take help of the old or the previous prescriptions. So to conclude, do a dilated checkup of all the patients with the 20 diopter or the 90 diopter macular for macular details. Do not depend on others' prescription. Personally see cases yourself for your or your trusted assistant. Repeat checkup of patient if patient has come for fixing date, even if seen 1 month before. Any doubt, please consult retina specialist. Any doubt, do OCT scan. All premium patients do an OCT, and avoid trifocal and multifocal IOLs in retinal problems. Thank you.
Any comments or questions? Okay, we'll take all the questions and comment after the session is over. Thank you.
So I would like Dr. Sudhir Parvani sir to please give our speaker, Dr. Sachin sir, memento, please.
Meanwhile, I request Dr. Sumit Agrawal to come for the presentation. छोटी छोटी मगर मोटी बातें, ये बहुत बढ़िया आजकल बनाने लगी जनरेशन जो है, विट्रेक्टोमी पल्स दैट मेक द बिग डिफरेंस. आजकल की जनरेशन जो है ना, वो टाइटल भी बड़े अच्छे से बना दी.
Thank you, sir.
टॉपिक वही होगा, प्रेजेंटेशन इंटरेस्टिंग कर दिया ना.
Good evening, everyone. Thank you, IDOS, for giving me this opportunity to present in this vibrant forum. Today, I will try to enumerate a few very simple things that in time I have felt that they have made a huge difference in my practice and has made this very unpredictable surgery a little more predictable, a little more stable for me as a surgeon. So these very small choices leave a big impact on your outcome, on your long-term outcomes, and ultimately, especially being in private practice, we rely on word of mouth. So one successful story will bring another case to you. So my first pearl for today is while doing scleral buckling, what I try to do in the initial phase is to open up the subtenon space. Many times due to a hurry or due to some other reason, we dissect but superficially, and the conjunctiva is opened up but the tenon space is not opened up very properly. So opening this tenon space gives a more clean dissection. It causes less inflammation post-operatively, and overall look of the eye is not that inflamed, and with less inflammation the recovery is very smooth. So if I try to show here in this video, so the very first step is important. The first nick that we give, that nick has to be in the subtenons plane. There you can see the conjunctiva and tenons separately, and once you enter this space, your dissection becomes more clean. The next tip is double stain, or otherwise you may peel only the epiretinal membrane. So this tip is more demonstrated in a better way through this small clip. In this video, we can see that the epiretinal membrane has been stained. It is somewhat stained, and then we peel off a sheet of tissue from the macula. This sheet comes off nicely, but then we stain again, and what do we find? That the ileum is still there. The sheet of tissue that we peeled was epiretinal membrane, and if we had left at that, we would have missed the ileum and we would have landed up in recurrence. So my tip is there is no harm in staining the membrane again. Many times we feel that the membrane that we have peeled comes off with the ileum itself, but many times that is not true, and there is no harm in confirming it again. The next tip is a complete fluid air exchange. This applies for when we are doing silicone oil removal. Many of our silicone oil removal patients keep complaining of floaters, and these are micro silicone droplets. Though there is no way to ensure 100% silicone oil removal, this little tip that I do helps in little better silicone oil clearance. In this diagram, we can see that the tip of the fluid air exchange probe is at the interface, the meniscus of the air and the fluid, where silicone oil droplets tend to accumulate more at the meniscus, them being lighter than water. And I've tried to record it. It's a little difficult to record because of the glare of the endo illuminator, but here we can see when we keep the tip at the meniscus, we can see more of silicone oil droplets coming in, and you get a better clearance of oil and a happier patient who has less floaters, because even if the retina is well attached, even the visual acuity is good, these floaters can be really troublesome for patients, sometimes so much so that we have to go in and do a revision silicone oil removal. So this helps in avoiding that. The fourth tip is we live in an era of MIVS. We have been taught, and it has been bashed into our brains, to go sutureless, to go sutureless, to go sutureless. But I feel that the closure of sclerotomy is not decided by the technique that you are doing, but on the look of the sclerotomy that we leave. And because of this leaky ports, we get a very a bad kind of a situation where we get subconjunctival oil. Subconjunctival oil, if it goes into that space, there is no way to take it out. You are leaving the patient's eye for life with silicone oil under the conjunctiva, and even if you have done a great job, visual acuity is 6/6, that subconjunctival oil will always keep the patient uncomfortable, unhappy. So we should leave our ego out of it. Even if it's a 27 gauge port and we feel that this might leak, then it's better to suture it. What I was taught in our fellowship is that if the opening of the sclerotomy is a little slit-like, then it is more likely to close on its own, and if it is more round-like, it is likely to leak. So there are a lot of factors which go whether you suture or not, but I don't think a blind blanket of not suturing these MIVS ports is good for the patient. Last but not the least, I have been seeing a little worrying trend in our retina practice these days, that retina is trying to compete with LASIK, with cataract, trying to sell convenience to this as we try to compete with the convenience of MICS and LASIK. But I feel that retina surgery is not a surgery of convenience. We are fighting for the life of the eye, and this and a lot of online material is available because of social media. Everything is available to everyone all the time, and so many young surgeons who are fresh out of fellowship, they see these videos and try to emulate it. Because of this, patients tend to get worse outcomes. What younger surgeons are seeing are decades of experience by surgeons who have perfected their technique over thousands and thousands of surgeries, and a younger surgeon simply cannot get that same result just by repeating the technique. A recent example of pneumatic retinopexy, I think most of our colleagues are familiar with this trend, that pneumatic retinopexy, some groups have started doing them, and credit to them, they are getting excellent results. They are doing pneumatics in GRTs. They are doing pneumatics in inferior breaks. Still, they are getting good results. But seeing these, I have personally seen 5 patients who have been tried pneumatic retinopexy but ended up in re-RDs, bad PVRs, and ultimately losing that eye. So my request to all surgeons here is that to have a realistic view of their skill, of their level, and then only go for the surgery. We should not be shy of advising strict positioning, of putting in oil, and of telling our patients that your vision may not be perfect, but at least we are trying to save the eye. We'll save your eye for sure. So 5 choti baatein, they become habits, and with time I have found my retina practice to be more predictable, more peaceful. My counseling sessions with patients are more of a friendly tone, despite the results in retina not being always perfect. So surgery कोई चमत्कार नहीं होता. छोटी छोटी बातों को इनकॉर्पोरेट करके हम असाधारण परिणाम दे सकते हैं. थैंक यू फॉर योर काइंड अटेंशन.
Can I ask Dr. Chawla to please give our speaker this memento? And next we'd like Dr. Devakant sir to join us on the stage.
Your presentation is in the lab. Is in the slide. No? Okay, fine. Yeah. Lab. They'll get the laptop.
By the time Dr. Devakant's presentation is getting ready, Sumit, very nice presentation, and you have covered very fine details and very nice tips. The silicon oil tip was very good, but if you can do a multiple FG, probably that will help you in removing that residual oil. As far as that leaking sclerotomy, again, because we Indian we use this cassette reuse 4 times, 5 times, then probably that will do. So what we also do is, if we are going for a silicon oil, we have to suture it. There is no choice. And even suppose I have opened a new cassette, even then now it is my habit, I put a suture on that. No harm in putting that. Vicryl लगा दिया, क्या हो गया? 10 दिन 15 दिन में absorb हो जाएगा, खत्म हो गया. And pneumoretinopexy, again, I think there has been a definite indication has been described in the literature. Everyone should follow that and not the individual. You can learn, you can see, but yes, not like as you mentioned about GRTs and inferior breaks. I don't think that should be a criteria for that. So good talk and good, nicely covered.
Sir, and as you said, I have managed more complications of pneumoretinopexy than done them myself. Nothing against the technique, but I think it's for select cases and should be utilized. Yeah. But now some people have gone very aggressive with PNR. So a few minutes for the sponsors of the session probably. But again, an important point to emphasize on about the Atmanirbhar Bharat thing, that this is the first indigenously developed aflibercept that we'll be talking about. Of course, I'm not an expert on how these things are developed, but I can add a little bit of my personal experience of using this drug as well. So all of us do understand that biosimilars are what? These are very, supposed to be highly similar to the reference product aflibercept in this case. And there should not be any clinically meaningful difference in terms of mainly 3 things: safety, purity, and potency of the product. So it's, developing this thing that too indigenously, it's a huge, project, and it's a very expensive project. A lot of R&D and research and investment goes into, coming up with a drug like this, and it takes a lot of time. So luckily Zydus has a state-of-the-art CGMP compliant manufacturing facility, which is as per the EU and US regulatory standards, and they have been approved by major global regulatory authorities as well. Coming to the composition of the drug, it is a non-infringing formulation, but it has the same active ingredient which have the same strength, pH and osmolality, so much so that the product presentation and of course the route of administration is also similar to the original innovator drug. And it has been compared to several batches of these 2 products have been analyzed and compared, and we'll also discuss how they are found to be similar. There are a lot of tests, almost 100 of tests and quality attributes, assays and tests that are performed. And it has been found that this drug, which was known as ZRC3285, it showed a highly comparable relative potency in terms of the VEGF binding. And also it was found to be stable for at least 30 months under real-time storage conditions as well. So after developmental stage, a very important aspect is the clinical trial part of this. And Zydus did a phase 3 trial, which was a randomized, double-blind, parallel group multi-center study, which basically compared the efficacy, safety, and immunogenicity of the drug. So I'll move on to the results of this. So it was found that, all patients in all of these aspects, it was found to be very comparable with the innovator drug. For example, when comparing the change in the BCA from baseline, it was found to be very similar. Patients who gained more than 15 letters at 12 weeks was also highly similar. They checked the changes in the CNV leakage area at 12 weeks, which was also similar. And changes in the central retinal thickness at 12 weeks was also pretty similar. Important point is that the immunogenicity analysis, was also similar in both the groups. And something, whenever we are trying a new drug, when coming to the safety part, there were no such serious incidences of adverse drug reactions when compared to both the usual ones like hemorrhage, eye irritation, pain, headache. All these things were commonly noted. So this study concluded that the phase 3 clinical study showed that the efficacy, immunogenicity, and safety profile of this drug was similar to the reference molecule. Taking this data to the regulatory authorities in June 2025, it was approved by DCGI, and in February 2026 by the NIB. So technically, it was proved to be safe to be used in the Indian market. And of course, a lot of real world experience comes into place. I'll just present two cases in the last few months that I've been able to inject this drug. This is case one of elderly female diabetic. She was a non-proliferative diabetic with center involving DME and had received multiple injections, which were mostly ranibizumab biosimilar in this case. So this is how she presented with large cystic spaces. My usual go-to drug in these cases is a steroid implant, but while counseling the patient, she was more comfortable with a non-steroid implant, so we wanted to try aflibercept biosimilar in this case. So this is the image after 2 months of injection. Very dry macula. I could see some small pockets of fluid there close to the center. So I injected another drug at 2 months. So this is 2 months following the last drug, and this is at 3 months following the last injection. So very dry macula, and the patient was maintaining good vision in this case. So we are seeing that it is maintaining the drying effect for a long period of time as well. Case number 2 is a male diabetic, again a non-proliferative diabetic with DME, and this time it's a treatment naive case. So I had given some injections, so I wanted to try in patients who have not been treated before. So again, a very good candidate for Ozurdex. This patient, a lot of hard exudates, big, huge cystic spaces. We went ahead and gave 3 loading doses of aflibercept biosimilar in this case. So this is the image after 3 loading doses. At the 5th month, we had some recurrence of the fluid. So again, we injected, and this is the last image, the last OCT that we have. So just to summarize that, and I feel I would like to emphasize again that it's a drug that has been developed indigenously. So when it comes to cost, these are very expensive drugs. So I'm sure it will help our patients. There have been a lot of clinical data, clinical trials that suggest that it is equivalent and non-inferior to the reference molecule. And so far, the clinical experience has been good. There have been some reports of some adverse effects recently, but mostly they have been due to the storage issues or the cold chain issues. That is what my discussion with the company was. So thank you so much.
Any questions from the audience or from the panel? So I would like Dr. Purkar sir to please.
So call Dr. Ashutosh Agrawal for the next presentation, diabetic vitrectomy, pulse and pitfall. Dr. Ashutosh.
Dr. Ashutosh Agrawal sir. Oh, yeah.
Dr. Devkar, does VRSI is withdrawn that advisory or it is still there? Withdrawn? So with NIRA there was some reaction and VRSI has issued a circular to use with the cautious, and Dr. Devkant has just updated me that advisory has been withdrawn. So now it is ready to use with the new batch.
Hi, good afternoon. So let's discuss the pearls and pitfalls while doing a diabetic vitrectomy. So case selection indications for vitrectomy in proliferative diabetic retinopathy are a non-clearing or a dense vitreous hemorrhage, a traction which threatens or involves the macula, or you can have a combined rhegmatogenous and tractional detachment as well, dense premacular hemorrhage, and in select cases chronic persistent DME with VMT or ERM or other vitreoretinal interface abnormalities. Pre-op considerations are that we do need a medical clearance for the surgery, and if the patient is a CKD patient on dialysis, it's best to operate the next day after dialysis because that is when the systemic control is at its best. And stopping anticoagulants prior to surgery, I usually do not stop aspirin before the surgery, but yes, if the patient is on clopidogrel, Coumadins, then I do prefer to stop them 4 to 5 days prior to the surgery. We do like to give pre-op anti-VEGFs in a lot of these cases. So the advantages are reduced intraoperative bleeding, which leads to better visualization, and because the membranes dry up, so it's the membrane dissection becomes easier. The known risks of pre-op anti-VEGFs are Crunch syndrome, and you may encounter worsening traction, especially if the gap between the surgery and the pre-op anti-VEGF is too much. I usually like to keep the gap as to 2 to 3 days. I like to avoid the pre-op anti-VEGF when the prolifs are more or less fibrosed, and if the patient has a dense vitreous hemorrhage, in such cases I do my B scans myself, and if I feel that there's no gross traction, then I tend to avoid pre-op anti-VEGFs in these cases as well. So the first important step while doing a diabetic vitrectomy is that you have to relieve the antero-posterior traction by trimming the vitreous cone. So in a lot of these cases, you will already have an incomplete PVD. You may encounter dense subhyaloid hemorrhage, such as in this case. In these cases, it is relatively simple to find the correct plane of dissection. And once you have made a buttonhole in the posterior hyaloid, then things become easy. So you can just trim the hyaloid all around 360 degrees. And that will help you in finding the correct plane of dissection, the second membrane, the so-called second membrane as well. It's important to trim the cone 360 degrees so that when you're doing the membrane dissection, you don't cause any peripheral breaks. Like I said, that in a lot of these cases, you will encounter an incomplete PVD. So in most of these cases, usually the PVD induction is done from outside to inside. But if you have a no PVD situation, you have no option but to do the PVD induction inside to out. So usually, so what is segmentation? Segmentation is that you have these neovascular pegs and you'll have bridging tissue in between. So with the cutter, you can cut the bridging tissue between these foci of pegs or fibrovascular adhesions and divide them into smaller mobile segments. So this is called segmentation. So this is just a very basic video of a very small segmentation. So you nasally have a very small prolif and a couple of neovascular plaques. So you just cut the bridging tissue in between and then cauterize the tip of the neovascular peg and you're done with it. We have slowed the videos down on purpose so that we can leisurely look at the segmentation. And nowadays with these high-speed cutters, actually you can do a lot of things simultaneously, induce the PVD, keep on doing the segmentation as well. Now delamination is then when you're trying to remove the membrane in toto and you're trying to pull out the pegs gently so that there is less residual traction or less fibrovascular tissue at the end of the surgery. So what we normally do is we use a combination of segmentation and delamination. Here I'm trying to induce the PVD as well, trimming the cone, and then we'll proceed with the membrane dissection. So you can either delaminate with your forceps. So the direction will be tangential and not perpendicular, so that you don't cause an iatrogenic break. And you should avoid pulling too much on points of strong attachment. There you can just go ahead with the segmentation. So once the membranes are loose enough, you can just put the cutter behind the membrane, behind the loose membrane. This is called a fold back technique. And obviously you can also insinuate the cutter beneath the membranes and do the segmentation from that angle as well. Control of bleeding is very important when you have very dense membranes, very adherent membranes. Bimanual surgery is when you use a chandelier light and you have a forceps in one hand and a scissor or horizontal scissor or a cutter in the other hand. But like I said, that now we have very good cutters, very high speed cutters, and I personally feel the need for a bimanual surgery less and less nowadays. If you have a no PVD situation, it's just best to pull it up from the disc, and slowly you will get the plane of dissection. But this just causes a lot of bleeding, so you have to control the bleeding. That's important because you may encounter underlying breaks in such situations. ILM peeling is now done in a lot of cases, and it does help in prevention of formation of post-operative epiretinal membrane or a macular hole. It's also useful in chronic DME. So once you have cleaned up the membranes to extent possible, I usually like to endolaser up till the periphery because see, the patient is undergoing a diabetic vitrectomy. So that means that the disease has progressed, maybe his metabolic control, etc., etc. So I do not want that the patient should land up in a recurrent vitreous hemorrhage. So I like to laser up till the periphery in most cases. A choice of dampener depends on the situation, on the surgeon and his preference. And we should try and avoid complications like residual proliferations, iatrogenic breaks to extent possible. Thank you.
Thank you, Ashutosh. Nice presentation, nice videos, and nice pearls you have given.
Next, can we have Dr. Prateek Mahajan sir here, please?
So, Ashutosh, you have made a very good point about that pre-operative anti-VEGF. It is a very good point, and just want to add in that a small pulse from my side. Before giving anti-VEGF, take physician fitness. ये नहीं कि injection लगा दिया and then patient is unfit for surgery. So make sure that fitness has been taken, that all clearance has been taken, then only go for it. And I personally feel that the video which we are pulling with the forceps was a little too hard. So probably उसमें anti-VEGF शायद नहीं दिया था. Probably क्योंकि bleeding भी बहुत था तो probably वहाँ पर थोड़ा सा careful. बाकी otherwise उसमें कुछ. So now all over you. तो भैया ईरान इराक पे जा तो ट्रम्प पे. I think he's a good friend of mine, so I can talk to him. All yours.
So let's talk about navigating vitreoretinal tamponade. Hormuz Strait oil and gas. So like if we talk about Hormuz Strait, only a right ship taking the right route can guarantee a safe passage. Even that will not guarantee. But similarly, our thought process should think about right tamponade at right time, and that will give a successful outcome. So why tamponade matters in vitreoretinal surgery? Actually, physics often determines the success of the surgery even before the surgery begins. We think about surface tension, buoyancy, and volume displacement. And our aim is to provide retinal apposition until laser adhesion forms. And our choice of tamponade depends on the pathology, patient, and surgeon's experience. Chemically, silicone oil is polydimethylsiloxane. It's a long-term tamponade agent and useful in complex retinal detachments, and it allows good functional vision post-operatively. It comes in different viscosities, 1000, 1500, 5000 centistokes. Lower viscosity silicone oil helps easier injection and removal. It is cost effective, but it carries a higher emulsification risk. 5000 centistokes oil can be kept for a long time. A word about Densiron Extra. It is heavier than water, so it sinks. It is ideal for inferior pathology, and a patient can avoid prone positioning when we use Densiron Extra. The complications of silicone oil. Well, cataract is a complication commonly seen. Sometimes the oil can come into the anterior chamber. A white hyperoleon can be seen when the emulsified silicone oil comes in anterior chamber. Band-shaped keratopathy. And sometimes all the good work is undone when we see a total optic atrophy because of the glaucoma in a nicely attached retina in a silicone-filled eye. The mechanisms are pupillary block, overfill of silicone oil. Sometimes it's the emulsified oil in the trabecular meshwork, and chronic inflammation and peripheral anterior synechia. Sometimes there is a recurrent retinal detachment after silicone oil removal. So these complications should be kept in mind. Coming to the gases, air, SF6, C3F8, these are the gases which are commonly used. SF6 is a shorter duration, helps in quicker recovery, is good for small macular holes or vitreomacular traction. But for cases of retinal detachments, we need a prolonged tamponade. So C3F8 is useful. The difficulties with different gases is a visual obscuration, because the gas, as the bubble dissolves slowly, so slowly the visual comes, and there are definite travel restrictions. And even if there is a small gas bubble, the patient should not be allowed to fly or go at high altitude, because it can expand to enormous proportions. There's a delayed return to work, and patient is anxiety due to bubble, because he will constantly call you and inform you, like, now today doctor I am seeing like this, again it has become I can see a black line, and it had become a ring line, and it has broken into multiple pieces. There's a chances of IOP spike, chances of pupillary block glaucoma with the gas. Then there's a feathery kind of cataract because of the contact of gas with the clear lens. Sometimes this cataract is reversible also. And slippage of the retina can occur, and then you have to go inside and again do a vitrectomy with a silicone oil. So sometimes the decision is taken on table, and it becomes a big question from the relatives whether you have put oil or gas. So if you visualize, the gas provides a tamponade to the superior retina, and oil provides support to the inferior as well as superior retina. When to choose gas? When it's a primary rhegmatogenous retinal detachment with superior breaks, it's a macular hole, and there is a good posturing compliance. When to choose oil? When there's an inferior retinal detachment, PVR, cases of trauma and recurrent retinal detachments, pediatric detachments, and poor follow-up or posturing compliance. If it's superior, so decision flowchart goes like this: superior pathology, use gas; inferior pathology or PVR, use oil; poor compliance, use oil; simple superior break, you can go for gas. So take home messages: no perfect tamponade exists. You choose according to pathology, patient, and your experience. Gas is elegant and temporary. Oil is durable and forgiving. A small video of silicone oil removal. see what Trump has to say.
The real reason for gas shortages, not war, it's the retina surgeon. Retina surgeons are using oil and gas in all their damn cases, and at what cost? Just to make the blind people see again.
Thank you so much.
Thank you, Pratik. Nice. You have covered all the point very clearly and nicely. Just want to know, you have removed that oil after 1 year in that case. What is the normal schedule you follow after putting oil? You remove after 4 months, 3 months, 6 months. What is ideally you?
No. So normally, like I follow the patient very close. When I put silicone oil, I remove it at like 2 months.
2 months.
I have started like since last 2-3 years. I have started following a very early as I have become more confident about my own surgeries. So I have started following an early removal of the oil because like when I feel when patients is under my follow up only, and I can remove oil and be comfortable with that so that the patient doesn't gets lost. And I'm seeing good results with that. Many times it's about time.
Nowadays people are removing early. Usually earlier the conventional training was about 4 months, 6 months. Now because of, as you rightly mentioned, because of the experience, because of the newer technology and equipment available with us.
Okay, thank you.
Do you have any experience with Densiron or PFCL tamponade?
No, not at all. There was a case, so I just studied a lot about Densiron, but finally that patient didn't turn.
Chawla sir.
Now, but I know it's like I just inquired, so now it is easily available. It is with Oro Labs. So there was a case, so I just contacted them also, asked them to supply also, but finally that patient didn't turn up. Yes, sir. The cost perhaps it's about 28 to 28,000 or something like that.
Thank you, sir.
Now we welcome Dr. Gajen Chawla to present his case of AI-based diabetic screening in rural areas. A very important topic for all of us. Pratik want another memento. He has received in the morning also. Pratik कितने लेगा ये बता दे तू तेरी talk है इतना सब कुछ नहीं आया इधर नहीं आया. So after so much of about vitrectomy and silicone oil and diabetic vitrectomy and all that, diabetic vitrectomy pearls and oil, gas. So it is diabetic day practically. So if we do this, I'm covering on that part where if we do a screening properly, probably we will not able to reach to that stage where we are talked about in this session in the morning. So I don't have any financial disclosures, and I give thank you to IDOS and the organizing committee for giving me the opportunity. As you know, due to the change in the lifestyle and food habits and hereditary reason, number of diabetics are increasing, and so the diabetic retinopathy numbers are also on rise. And India is the diabetic capital. So as of now, it is approximately 90 million diabetics are in India as of today in 2024's data, and it is expected or it is projected it will increase to 157 million by the 2050, and almost 12.5 to 20% of these diabetic patients may have some form of diabetic retinopathy. It is according to the different literatures. And 3 to 7% of all these diabetic will have a vision-threatening complication. It is a huge population. And the problem with this diabetic retinopathy is in early stage, it is asymptomatic, but in the When the patient comes to us, it is already advanced stage. So I have started doing diabetic retinopathy screening program since 2008, and I have seen more than 90,000 patients so far of diabetic screening. The initial phase, it was the manual type of screening when we were seeing the patient with the indirect, going to the camps. 6 days I work in the hospital, and on 7th day, Sunday, I was going to the camp in Bhopal and surrounding areas, about 8 districts I was covering. So, and that was the days when we started our first project. It is a very gold standard. We can have a direct diagnosis, no dispute, no grader is required, nothing is required. But it is not scalable and it is time consuming. That was the hurdle. Then comes in the second part of my journey was the teleophthalmology, in which the retinal photography was done using the portable fundus camera. And the image was read by the retina specialist or the trained diabetic reader at the base hospital. Yes, it is the advantage of teleophthalmology was the remote access. We can have a remote access. It is scalable, but the bottleneck of this model was grader availability. There was a lack of graders available, and poor internet connectivity is in a rural area is still in some areas it is an issue. So over the 3 decades since ever I have started this screening program, there was certain challenges because this number of diabetes is increasing. That limited accessibility in the rural and low income group, they are not having the facilities, they are not don't have a finance with them. And as Tina was discussing about in that debate in the previous session, the ophthalmologist is very less to the in relation to our population. So it's almost if one ophthalmologist has to see the patient, he has to see about 52 to 53,000 patients in his lifetime. So it is a very big amount which is not possible. So we need a innovation, and where this AI comes in. So we have integrated the AI into our community screening program with our project of Project Care, which we have started last year. We want to see how the AI, this offline AI assisted, how it is feasible in community screening, how the it is giving the result in, and how we can validate our own data. So we do camps in the community setup, in all camps in Bhopal and surrounding district, we have recruit about 975 diabetic patients so far in this particular project. Every patient has the vision recorded and fundus photos captured by a technician using the non-mediatic camera. And there is offline analysis, as Dr. Tina says, 20 seconds you get the report whether it is a patient is even diabetic or a possible diabetic or it is ungradable. All patients having the diabetic retinopathy possible and ungradable image, and 10% of the patient who was having a negative diabetic retinopathy, those all patients we have seen. 10% of the normal patient also, so that we want to validate whether this camera, this model is whether working right or not. So we have to check ourselves. So those patients we have seen. We have seen about 975 patients so far, and most of the patients were from the older group and with the longest standing diabetic populations. The prevalence in our series is little high, about 19.7%, because when we announce the camp and we do publicity, we make it sure we write there diabetes के मरीजों के लिए camp. So it is exclusively for diabetic, but in Indian population, non-diabetic population will also come. So but because of that, our diabetic participation in that camp is more. So we get a more number of diabetics, and so more number of prevalence is there. And the similar way, the VTDR rates is also little high in our this thing. And we have during our this camps, we have taken some questionnaires and we have asked for whether the patient was aware about the diabetic retinopathy or not. So we have found that the area where the awareness was there, the patient was having, they know case diabetic can affect the eye, there the incidence of diabetic retinopathy is less. And where there is the awareness is less, the diabetic retinopathy is more. So it is directly related with awareness and programs. But there was a glitch in that. Out of 818 patients, which is that diabetes caused the damage. They were aware of that diabetes can cause the damage. Out of theirs, 60% patient, almost 60% patient have not gone the retina examination before that. They were knowing yes, diabetes can affect. So it is a hidden threat for us. मुझे पता है कि डायबिटीज से आँख खराब होती है और मैं चेकअप नहीं करा रहा हूँ. So that is again a hidden threat for us. And out of these, the patient who has not undergone the treatment they were aware of, in this group also almost more than 10% patient was having the diabetic retinopathy. So this proves the point that awareness alone does not ensure the prevention. So you have to act little more actively as a retina surgeon. So as I mentioned about our diabetic prevalence was more because of more of diabetic population, and same was in VTDR cases also. AI performance was good. The Google algorithm was about showing that 97% sensitivity and 96 specificity, and in offline it was in our series was sensitivity was about 85% and specificity was about 90%. The average time for per scan was about 5 to 6 minutes. Means one technician with one camera and AI enabled camera, they can see about 10 to 12 patients per hour, and patients were very comfortable. They were accepted that yes, this is a diabetic this AI camera, and they are ready to undergo this. Then they are very comfortable. So offline AI worked seamlessly. It is because even when there is a poor connectivity in the village, image can be uploaded later. But there are certain challenges, as I mentioned about, it is lack of awareness about the diabetic retinopathy in general population. Even medical doctors, they are not aware of yes, diabetes wale hain ka eye checkup karana. That is again the problem here. There is insufficient number of retina specialists, as which I already mentioned about, and there is a poor follow-up of the diagnosed patient. Almost 20%, whatever the patient we have seen and we have diagnosed, only 20% of those patients comes for follow-up to the hospital. So we have to adopt the annual screening rate. We have to enhance by active community drive, and we have to look for other modality also, like going to the diabetologist, going to the NCD clinics, and training, give the training and awareness to program to that. We have to use the digital platform as nowadays the things are going on. The training of medical paramedical personnel, sir, 1 minute का और चाहिए मेरे को, and we have to maintain the digital diabetes registry. So we have to improve the follow-up adherence. We have to train the AI model further for the Indian database to enhance the sensitivity of mild retinopathy, and we have to integrate the diabetic screening into the broader network. To conclude, AI assisted telescreening is practical and scalable. Awareness alone does not ensure the prevention, so we have to have a targeted education, and then we have to look for the geographic strategy where the diabetic retinopathy is more. We have to go work more. Thank you for patience hearing, and sorry for exceeding time for a few seconds.
Thank you, Dr. Chawla. You enumerate very good things, but things are not improving as such. In city also, patients and doctors, they are not seeing, consulting the retina or for retina, and in village also. So incidence is already, incidence of diabetes is increased in proportion to diabetic retinopathy. But it is the same. If you increase diabetes, the retinopathy also has increased, but not to examination.
Yes, sir. That is the problem, because I was since ever I'm using this AI camera. We met an n number of diabetologists in Bhopal. In Bhopal, I am talking about Bhopal. They are not referring the patient. In fact, I have kept camera in 2 of the diabetologist clinic. There, the incidence of diabetic retinopathy of those 2 I kept for 2 months for in 2 different diabetologists. And they have examined more than, because I have not incorporated that data in this study. There they have seen about 110 patients each. Out of 200, the incidence of diabetic retinopathy in their clinic, because patient is asymptomatic when they are going, it is 16.7%. But they have not referred those patients to us. Even I have given my cameras to them. Even then they are not sending. So probably, sir, when I started my this journey in 2008, जब पहला कैंप लगाया था तब लोग बोलते थे ये डायबिटीज आई कैंप का कोई भी होता है क्या? But at least now people are talking. We are having a good number. So we have to work hard. We have to work hard.
I am working in a diabetic clinic setup.
Yeah.
And I go there daily, and I get an opportunity to see between 5 to 10 patients every day for screening.
Yes.
So that way, from our end, we are having a sufficient number of.
Yes, yes, certainly, sir.
Secondly, for AI model, you have to give the AI a fundus photograph to evaluate.
Yes, we have to capture the photograph.
Photograph and give it to evaluate. So until unless you have a 9-segment photograph, you will not be able to completely see the peripheral changes of diabetic retinopathy which are occurring. Only central photograph will not suffice for evaluation of diabetic retinopathy. Number 2, AI will only find out whether there is a diabetic retinopathy and what grade of diabetic retinopathy it has. All other retinal diseases are going to be missed in that patient if not screened properly. So that is one limitation of AI which is there, because it will say no diabetic retinopathy. The patient may be confused that he has no eye problem as such. All ARMD patients who belong to the same age group will be missed for that.
Sir, the camera which we are using.
And secondly, they are not recording the vision.
Yes. Sir, because with this cam, where we are going, we are recording the vision. My technician is recording, because this is somebody has to take the photograph. This is the technician who is taking. So what the AI, offline AI which camera we are using is from Remido. They are good for diabetic retinopathy. They are good for AMD. They are good for glaucoma. So it is, yeah, I agree with that. Every retinal disease they cannot diagnose. So, but at least, sir, we are talking about diabetic population which is so used. Say 100. Sir, this particular data which I have shown you, this is totally supervised by the ophthalmologist, because in camp my son is going so far. So all of this 900 patient, it is either from my clinic or from the periphery where my son is going. So this is 100% seen by us. So we, sir, ungradable images. Yes, definitely we have to put our this thing. So this is combined data in that. So about 10%, 10 to 12% patient was having the ungradable images. The only flaw which we have found that case of this RVO. 1 or 2 patient was RVO was labeled as a diabetic retinopathy. So that at least that patient was having some retinal problem. We have seen that. In our this thing is about 85% is specificity and 90%, more than 90% is sensitivity.
For the diabetic retinopathy screening purpose, we can have a single photograph of 30 to 45 degree, including the disc and macula, is sufficient for screening only.
Screening, yeah, it is for screening. And any patient who is having the positive thing, then definitely we are sending to the ophthalmologist for further revision. At least जो negative है वो निकल गया ना सर, तो आपका लोड कम हो गया. ये सर पूरा सर वो पहले का जो होता था ना सर, अब ये AI आने से थोड़ी सी चीज चेंज हुई है, इसका तो फर्क पड़ा है. Thank you so much.
Agrawal sir, if you could felicitate.
अच्छा नहीं इसके अंदर प्रेजेंटेशन पीपीटी में
सही बात है.
Should I start? Good evening, everyone. I will be talking about drying and durability of brolucizumab. These are my disclaimers. It is a sponsored talk. So fluid plays a significant role in AMD and DME management. So center subfoveal thickness and fluid levels are important in pathogenesis of both NAMD and DME. Guidelines recommend that treatment decisions should be based on the presence of fluid on OCT. Persistent fluid often leads to lower vision gains in both NAMD and DME. These fluctuations may be associated with poor vision gains. So, an agent that dries faster and better should be associated with a good visual acuity. So, as we know, the patient adherence to multiple injections is very less in Indian scenario, and there is a high injection burden to these kind of patients who need multiple injections throughout the year. And many patients don't even receive the optimal loading dose because sometimes patients fall out of the loading dose regimen. So coming to brolucizumab, it is the smallest commercially available anti-VEGF for an intravitreal injection. It is a single chain antibody fragment. So it is just a small fragment of the antibody. So it has better penetration. So it reaches up to choroid. So I will be sharing few of the cases with you. This was a 68-year-old female with diminution of vision since 3 months. So this first aflibercept injection was given. There was not much reduction in the PD height or subretinal fluid. The second injection and the third injection was given, but the PED didn't settle. So after the loading dose was complete for this, I decided to shift the patient to brolucizumab. So this was after first brolucizumab. The patient recovered completely, and then after 4 to 5 months, the patient again had the same episode, but now the patient is on repeated doses of brolucizumab. Every 4 to 5 months, the patient needs the injection. Coming to second case, 74-year-old female with diminution of vision in right eye, hypertensive since 15 years. BCVA right eye was 618, left eye 69, IOL both high. In the right eye, there was ST-BRVO with macular edema. So this was the presenting picture, pre-injection. Then first ranibizumab was given to this patient. Then the patient recovered to vision of 6/9. Again in February, patient developed macular edema with large foveal cyst. Again ranibizumab was given and there was complete resolution. And again after 2 months, patient had recurrent edema with this time NSD also. This time I tried Ozurdex in this patient. Then till September, patient was fine. This was the OCT in the September. Then in December, again patient presented with a large foveal cyst and a macular edema. This time patient didn't want Ozurdex injection, so we again came back to ranibizumab. There was a lesser resolution this time as compared to the last injections. Then again I counseled the patient that will try Ozurdex. So again patient had complete resolution following Ozurdex. But then again after a month, patient developed spongy kind of edema. So I decided to try Paginex in this patient. So after first injection, there was no resolution. It was almost same. So I decided to give another Paginex for this patient. Then the patient's central thickness was reduced. Still she had some non-central involving edema, but vision improved. So this patient is also on Paginex. She needs Paginex 3 to 4 months, after 3 to 4 months every time. Thank you. So normally Paginex I am not giving after 4 weeks. I repeat it after 6 weeks. Even for the loading dose, I give at an interval of 6 weeks. So there has been some complications in not in my patients but overall. So that's why it is not much used overall. So I don't give this in a night patient, and all the patients in whom I give Paginex I call after a week just to check the anterior segment or any signs of inflammation. Depends, sir. If the patient has PCV or CNVM, then I give them this option. In diabetics, I don't normally give this option. Avastin, I've reduced giving that option to the patients. Very less.
We come to the end of this session.
Any questions from anybody? Thank you, Rohit.
Thank you.
Thank you, sir. Sir, पहले बहुत सारी
So thank you everyone. We have come to conclusion of this retina session. So we'll please all come here. We'll take a photograph. Whether it's a retina group or non-retina group, please come. Speaker, audience को सबको आना चाहिए साथ में. Doctors, audience आ जाए. हमको लगेगा सही किसी ने तो सुना हमारा.
अच्छी होगी तो